Well, welcome everybody. We are so excited that all of this has come to fruition today on April 2nd, a beautiful sunny day in Portland, Maine. I don't know what it's like in Cleveland and other places where people are coming to join us. I want to welcome you to this is our second training for the academic year. We are come to you sponsored by HRSA, which helps fund our programming. We are the Triad Project, Training in Aging and Diversity. And today we're really going to explore some subjects that often don't get deeply addressed: elder abuse, substance use, and crimes against older adults. Next slide, Tiara. So we have to do this disclaimer for today, and you're welcome to read it. And then next, Tiara, would you like to move us in? Thank you.
John, 58-year-old man, born in Armenia, living in a duplex in Portland. Mr. Bogosian lives in the first floor apartment with his granddaughter Pauline, 32, his sisters Ramilla, 69, and Sylvia, 71, live upstairs. A younger brother, David, died in 2001. The Bogosian family left Armenia in the early 1950s, devastated by the 1916 Armenian genocide, losing many friends and relatives. Mr. Bogosian became a U.S. citizen and successful entrepreneur, supporting his sisters and extended family. Mr. Bogosian founded and ran Bogosian's Market until 3 years ago when his wife, Anna, died.
I just didn't have the heart to run the market after my dear Anna died. I sold the place. It was time to retire. But my health was still good, so me and the sisters took care of ourselves quite nicely.
Recently, however, severe abdominal and back pain brought Mr. Bogosian to the hospital's emergency department, where the doctor diagnosed him with kidney stones. A follow-up visit to his PCP led to more diagnostics, which lasted for months.
After all those tests, they found out that Johnny had cancer, stage 4 kidney cancer. Not good at all. We wanted him to get the best medical care, anything to keep him around for as long as possible. But my brother is as stubborn as they come.
I know Rami only wants what's best for me, but I've taken care of myself and my family all my life. I don't need no one's help.
Mr. Bogosian's condition slowly but steadily has taken its course. He's now receiving palliative care and pain management through a home hospice program.
At my age, I can't take care of Johnny's physical needs. So me and Father Petrosian convinced him to hire a home health aide. I wanted what was best for John. He took care of us, and we wanted to give him the best we could.
Too many strangers in the house.
He finally gave in, and we interviewed several people. We selected Carla. She worked for a reputable private home health agency. We heard about it on TV. She seemed nice, and he and Pauline, my niece, get along. John pays Pauline to do odd jobs around the house. That is, until she gets a full-time job. Please God, she'll get a job soon. So it's Pauline and Carla. They help Johnny.
It's my job to help with seniors' physical care and their medication management. They can really mess up their pills and hurt themselves.
Phyllis, the hospice nurse, and Donna, the social worker, visit Mr. Bogosian weekly to check out his physical well-being and to update his hospice medication kit.
Mr. B is such a gentleman, very stoic about his comfort. I know he's not thrilled with us coming to the house, but he's never rude. Lately, though, during his physical exam, I noticed unexplained bruises on his body, mostly on his legs and arms. One on the back of his neck, too.
It's just my old age clumsiness.
Yeah, and he's been asking for more and more medication, though he rarely talks to either of us about his pain.
I should be able to ask for what I need, and I need more medications for my pain.
It's a bit baffling. He's quiet, but I have no doubt that he's all there and quite with it and responsive to anything we ask.
But he does seem to be more emotionally fragile, teary, tired, more withdrawn. It's concerning. And Pauline or Carla are always within earshot. They seem to make Mr. B nervous, and it makes me nervous too.
I'm just looking out for his welfare. Papa doesn't like strangers, and I'm here to protect him.
Hey, I get paid to take care of the old guy. I don't like it when my professionalism is questioned.
During their most recent home visit, Phyllis and Donna observed several of Pauline's friends and Carla waiting around in the kitchen. Mr. Bogosian appears uncomfortable, shifting around in his chair and avoiding eye contact with them. He also looks to Carla for direction in response to any questions.
He definitely wasn't himself today. Maybe there were too many strangers in the house for his liking, but honestly, it didn't sit right with me.
Me either. I'm worried for Mr. B.
So welcome again to everybody who's here. You've now met Mr. Bogosian, and you will hear more about him during our speakers' conversations, and also get a chance to talk about him in our breakout rooms. I am Shelley Cohen Conrad, the director of the School of Social Work, and also the director of our Center for Excellence in Collaborative Education. And as I said earlier on, today's workshops will offer a lot of information about topics that aren't often presented. And our goal is to have you learn from professionals in the field about these areas of practice through short talks, but we will have a really good session debrief later in the morning. We really would like you to participate. Please do not feel shy about putting some questions. As our speakers speak, they've all agreed to answer your questions as they're talking, and we will monitor the chat for you today. Before we begin, I want to take a brief moment to reflect upon the uprise in anti-Asian racism and its impact on older adults in our community and nationally. Anti-Asian racism has roots in the same anti-Black, anti-immigrant, anti-Indigenous, and anti-Semitic beliefs that built institution truths and structured aimed at privileging whites and those with means and power. As we listen today to our speakers, we need to be cognizant that ageism and violence against older adults cuts across race, class, gender, sexual orientation, gender identity, faiths, all kinds of factors which intersect with growing older. Thank you. And here we have the schedule for today. It's been put in the chat so you can follow it. And I'm ready for the next slide here, Tiara. So these are our learning objectives for the day. We want to identify resources to reduce, prevent, and intervene in the abuse and neglect of older adults. We want to define the impact and scope of healthcare crimes against older populations perpetrated by providers, family members, caregivers, and others. And we want to analyze substance use and the risk of prescription drug diversion in the lives of older adults. And all of our speakers will address these. Next. So now it's my pleasure to introduce our first speaker. Erin Salvo is the Associate Director of Adult Protective Services in the Office of Aging and Disability Services within Maine's Department of Health and Human Services. Erin has been in her current role since 2017, and she is an attorney by training. Erin, welcome, and we look forward to your presentation.
Thank you. So during my time this morning, I'm going to take a few minutes to explain what Adult Protective Services is in Maine, and also cover how we define abuse, neglect, and exploitation for our work, as well as look at some red flags and what our process is when someone calls Adult Protective Services. Very broadly, our high-level authority is to protect incapacitated and dependent adults from abuse, neglect, and exploitation, and situations that present as a substantial risk of abuse, neglect, or exploitation. And I'll get into a little bit of these definitions momentarily. I think a key feature here is this substantial risk of abuse, neglect, and exploitation. We don't have to wait until someone has experienced abuse, neglect, and exploitation. There are situations where the risk of that is reason enough to call Adult Protective and for us to be able to become involved. Very generally, our duties are to receive, investigate, and determine the validity of the reports that come into our intake line, take appropriate action, whether that's arranging for services, making appropriate referrals. And then as a last resort, we have authority to petition for public guardianship or a protective order, but that is very rare. And if you're familiar with Adult Protective Services, you might know that we have kind of our investigative branch as well as our public guardianship branch. And I'll be mostly focusing today on the investigation piece of our work. As I mentioned, here are some of the definitions that are very important to the work that we do, kind of define the scope of what we're able to do with clients. We think about the clients that we have authority to work with. In Maine, there's no age limitation. In some states, Adult Protective Services, someone has to be over 60, for instance. But in Maine, anyone who's an adult, 18 or older, who is either dependent or incapacitated may be eligible for APS to become involved. And the definition of a dependent adult is much broader. There are many more people who would qualify as being dependent compared to the definition of incapacitated. And the language that is on this slide is pulled right from our statute. So someone who's dependent is anyone who's wholly or partially dependent on others for care and support, whether that's due to a physical limitation or some other type of emotional or mental functioning is the language that's used in statute. So if someone's a resident of a nursing home, if someone receives services, one of the main care waiver services, for instance, they may qualify as a dependent adult. Whereas an incapacitated adult is someone who lacks the ability to make and communicate decisions on their own behalf. And the key feature there is that the person lacks the ability to make and communicate decisions, not make and communicate good decisions. And here, that's where we get into the idea that adults have the right to make poor decisions, so long as they understand the reasoning behind those decisions, essentially. And the distinction that's really important for Adult Protective Services here is that someone may qualify for Adult Protective Services as being dependent, but if someone does not lack capacity, they have the option to decline APS involvement. So we can arrive at someone's doorstep and they can say, no, thank you, I don't want to work with APS, and that's okay. It can be frustrating, it can be a little worrisome, but individuals do have that right, and we have to respect that. We try to leave the door open, offer services if we're able to, and encourage people to get in contact again if they change their mind. But that's something that we work with, and that's an important distinction for us. Turning to the definitions of abuse, neglect, and exploitation, abuse may encompass physical abuse, emotional abuse, as well as sexual abuse. And we also keep in mind that abuse includes both acts and omissions. So for instance, if someone requires assistance with mobility from a caregiver and that caregiver decides, no, thank you, I'm not going to help you get out of bed today, that may very well constitute physical abuse. Neglect is a little more of the caregiver has the role of assisting someone in meeting their needs and is not doing that. So not providing someone with sufficient food, clothing, shelter, or if someone requires a certain level of supervision that they're not receiving, that may qualify as neglect. And then exploitation, we often think of that in terms of financial exploitation. Many people think that the primary financial exploitation we may deal with is kind of the online fraud and scams that we see, but it's far more common that we're dealing with not unknown perpetrators, but family perpetrators, or someone who's close to an individual who's either, forging checks, taking money directly out of someone's wallet, trying to get someone to sign legal paperwork that they don't understand. Those all would qualify as financial exploitation from our perspective. And then also other types of financial exploitation or non-financial exploitation, but medication diversion, for instance, or failing to get someone's informed consent may also qualify as exploitation. And it is not uncommon that we see more than one category of abuse, neglect, and exploitation in a single investigation, either reported at the outset or uncovered over time during an investigation. Just a few red flags to touch on, and I'll distinguish between red flags and risk factors. I mean, there's a lot of research around some risk factors that impact people and the likelihood that they may experience abuse, neglect, and exploitation. For instance, social isolation is a big one, and we see that especially concerns around the impacts of COVID and social isolation would be a major risk factor, as well as someone who has a diminished capacity or changes in capacity over time. That may be a risk factor for abuse, neglect, and exploitation. Whereas red flags are indicators that abuse, neglect, or exploitation may already be taking place. And this one is, I think, highlighted well in the Reader's Theater, the first one on this list, a caregiver who takes over. Sometimes we think of that as a Velcro caregiver, the person who always wants to be in earshot. They want to be involved in the conversation, perhaps speaking on behalf of the older adult rather than allowing that person to answer the questions or discouraging that person speak privately with anyone. In EPS, we do have a requirement that our staff, our caseworkers who visit with someone have to speak privately with someone to the greatest extent possible. I know many times a caregiver is well-meaning and wanting to be supportive of the person that they're caring for, but we do have a requirement that conversation happen privately for exactly this reason. Similarly, if an older adult is seeming anxious or fearful or submissive around an individual, that may be a red flag that there's something going on as well. If an adult suddenly has no understanding of their financial status, or they are aware that they've signed something, but they're not sure what, certainly a red flag. Sometimes we see instances of new friends or strangers who have arrived to offer support, and that can be concerning as well. And I think the biggest one, last on the list here, is changes. And certainly that's harder to identify if someone's not very familiar with an older adult, but if someone is, then noting those changes over time, things that may be indicating a decline in cognition or a decline in someone's emotional well-being due to abuse that's going on. Could be things like changes in appearance, no longer wearing weather-appropriate clothes, a sudden change in mood or behavior. All might be indicators that there's something going on that needs to be looked into a little bit more. So I always encourage folks to ask questions and see if the answers make sense or if the answers change over time. Listen carefully to what you're saying, and alongside that, just observe. Does the situation altogether match what someone's describing? Those would be some of the key features I would highlight in terms of what we see as some of our most common red flags. I can say, we get a lot of reports from bank tellers. They're great reporters because they see their customers on a regular basis. They notice those changes over time, and they notice if someone new is showing up with someone who has a very important interest in that person's finances. So it's kind of just being on the lookout, and sometimes it's really that gut feeling. Turning a little bit to the Adult Protective Services process in Maine, we have a central intake line that's available 24 hours a day, 7 days a week, the 1-800-624-8404 number. Now, I should mention that even though we accept calls 24 hours a day, we're only conducting investigations during business hours. If someone is a mandated reporter to Adult Protective Services, then our statute requires that be a phone call to our 1-800 number. But we also have an online form that's available to people who are not mandated reporters. At the intake stage, the goal is for our staff to identify, is this a case where the person involved meets the definition of incapacitated or dependent, and is what's being described abuse, neglect, or exploitation. If it meets those standards, then it's what we call screened in for APS. The second part of the screening process is determining our priority level, meaning is this a case where APS needs to go out within 1 business day? There's a more urgent concern, or is it something where we may have a little more time, in which case our rule allows us to go out within 5 business days. From there, the case is reviewed by a supervisor in our district office that's closest to the county where the client lives. Some cases can be closed at the supervisor level, reason being if it was something was just recently reported and closed, already open for investigation, things like that. And if it's not closed by the supervisor, then it's assigned to a caseworker for a field investigation, where the primary goals are to determine someone's safety, see if there are some services that may be available to the individual, and then also see if there's a sustainable plan that can be put in place before APS leaves the picture, and is there abuse, neglect, and exploitation going on that should be substantiated. And in some cases, if there's a concern that an individual is incapacitated, we do what is called a guardianship study, which is where we look and go through a process of determining, is this person incapacitated? Do we need to get a medical assessment to determine that? And if so, do they need a guardian? Is there a private individual who may be able to serve in that role as a guardian? And if not, should we be petitioning as the state to become someone's public guardian? In all of our cases, we are collaborating closely with many different groups. If there's a concern that what's being reported is criminal in nature, we're going to work closely with law enforcement and follow their lead generally to see if we can either coordinate for interviews or follow law enforcement for interviews. If allegations are taking place in a facility that's licensed, we work with our Division of Licensing and Certification. And then very frequently, we're working with different advocacy agencies, groups like Legal Services for the Elderly, Disability Rights Maine, the Long-Term Care Ombudsman Program are all common organizations that we work with. And then at the conclusion of every investigation, all of the notes are included in our electronic system to preserve the record of our investigation, and the determination about whether any abuse, neglect, or exploitation is substantiated is documented. This is important because we do maintain a registry of perpetrators. There's a law that was just passed this past year that allows us to expand this registry. Previously, it was only related to clients who had an intellectual disability or autism, but the law that just passed expands that. So any individual who's incapacitated or dependent and is abused, neglected, or exploited, that perpetrator may be placed on this registry, and then different providers of main care services have to check our registry as part of their hiring process in making employment decisions.
Erin, you have a few questions if you wanted to.
Yeah, absolutely.
The first was Elena George on roughly how many made each year?
How many reports are made each year?
Mm.
We receive about between 600 and 800 reports a month. And the one thing that I can say is that year over year, we receive more reports every year when we compare the reports that we're getting. So it's been about a 10% increase year over year the past few years. I will say we saw a major decline in the early months of the COVID-19 pandemic. We saw about a 25% decrease in March, April, May of 2020 compared to those months of 2019. And then it's kind of come back online in terms of where we would expect it to be. So getting into a little bit, maybe more detail than was asked for, but.
There's a question working with elders from varied immigration. um, or status groups, family groups, when family members may be the only source of culturally congruent support, and getting law enforcement involved could be potentially re-traumatizing. Do you have any comments on that?
Yes, I'm trying to pull up the chat so I can see myself, but I'm having trouble with that. So I think the question is basically being culturally sensitive and understanding what that role is in our investigation process. I will say that at the start of any investigation, we have a requirement that we contact the local district attorney's office. So that is something that we have to do in every investigation. But then from there on out, our role as APS is really to follow the lead of the client. Like I mentioned, if someone is dependent, so if someone is guiding our work, that's how we're going to follow it, and trying to make sure that people are, able to be in a role of self-determination to the greatest extent possible. And that can mean many different things for many different people.
Okay, thank you. And there's several more coming in. I don't know if you want to continue and then pick these up a little further in, or what you'd like to do.
Let's keep going with the questions, because I'm kind of I zoomed through, I think, the slides. There aren't too many left anyway.
Okay, great.
So we have a question that asks, is the increase in reported cases due to better awareness and confidence, or just an increase in abuse? And are there any identified trends?
It's a great question, and we don't have data to support a solid answer one way or the other. But I do think that in the past several years, we've done a lot more in terms of outreach to organizations and trainings events like this that can contribute to the general awareness. So I'd like to think that it is not just a straight, there's more abuse in Maine than there used to be. I don't think that that's true. I think that it's really that people are reporting more frequently, and becoming aware of their role as a mandated reporter even is one piece of that.
Thank you, Erin.
Then we have one more, Erin. How has COVID impacted reporting? You seeing an increase, you think, related to COVID? And this individual's in Massachusetts and said that there's a lot of confusion there, and people, it's just, I think it's been impacting. Strangers are getting involved when they normally wouldn't have.
I think that's also a great question, and it has been a major cause of concern for us. Like I mentioned, social isolation can be a major risk factor that impacts whether someone's may be subjected to abuse, neglect, and exploitation. I certainly think there are some individuals who take advantage of that. And if you don't have, so for instance, if someone typically had a few hours of caregiving services that are being provided in their home, and then that's no longer happening, you just don't have those eyes and ears to get a sense of what's going on, especially for someone who's homebound. And just kind of that overall hesitation to be around other people doesn't help with that. So like I mentioned, we had a major decline in the number of reports that we saw early on, and I think we're getting back on track in that regard. We were able to put a public service announcement together in the summer of last year to encourage reporting. And that, I think we heard from a handful of folks who called the intake line and said, I'm calling because I saw this public service announcement and I have this concern about someone who I haven't been able to check in on. And we are planning to issue a few more public service announcements based on that, because of the increase in social isolation that we're seeing due to COVID. We also, as out of an abundance of caution, have decreased our in-person presence in some cases, where normally our caseworkers go out and do an unannounced initial visit with someone, recognizing that is especially concerning to someone, and we don't want to do more harm than good by spreading COVID unknowingly. That was a choice we made early on And that definitely makes things difficult. Trying to assess someone's safety over Zoom or FaceTime is nearly impossible. So that has impacted our ability to complete some investigations. But I'm hopeful that, as the weather gets better, we can meet people outside again. And also through, vaccine efforts, we'll be back on track and more back to our normal process very soon.
Great, thank you.
So I will just touch on our public guardianship and conservatorship program that I mentioned a moment ago, which is really our kind of last resort tool in the toolbox for clients who lack capacity. What we ultimately would be doing is petitioning the probate court to serve as someone's substitute decision maker if they're not able to make decisions on their own behalf. So we're looking at, is this absolutely the last thing we can do? Are there other alternatives? Someone serving as a power of attorney and a rep payee, supported decision-making, things like that. We have to look at whether there's an emergency basis for guardianship or if we can go through the standard process that the court requires. And also identifying, are there limits that we can place on ourselves as guardian? Does someone actually need a substitute decision-making in every category of decision-making, residential, financial, medical, et cetera? Or perhaps does someone only need a guardian in one realm, one or two? And then once we do have public guardianship, our program is really focused on ensuring that that person has the needs that their needs are being met, monitoring the quality of the services they're receiving, administering their assets, and then making decisions on that person's behalf. And again, even if someone lacks capacity, we want to make all of our decisions in line with the person's right to self-determination. So engaging the person as much as possible in what they would want if they could make that decision, and trying to identify what are their values and beliefs and opinions on the decisions that are being made for them to the greatest extent possible.
So, Erin, that's a great segue for the question I put in the chat. Mr. Bogosian and his family have come from a certain culture where asking for help isn't something that you do. Can you comment on the case from your perspective from Adult Protective?
Absolutely. So I think one piece I would mention is we're APS to assess Mr. Bogosian. We're not clinicians, but it seems like he probably does not qualify as someone who lacks capacity. So it'd be totally up to him whether he would want to engage with Adult Protective Services or not. I know it is not uncommon that the folks that APS works with are fiercely independent and private people who are not ready to have assistance from Adult Protective Services. And so it would be kind of that conversation of, here are some things that we could offer if you're willing, and kind of guiding that conversation and seeing if he's comfortable with APS remaining involved or opening up to APS about what else may be going on. But without that, it would be very difficult for APS to remain in any kind of central role to explore what's going on.
So we have another great question in the chat from Kate, who says, is there any formal training or communication with occupations such as bank tellers or others not in health or not in behavioral health or service, because they are in such unique position to spot issues with elder clients, elder people?
Specifically when it comes to financial institutions, we have partnered with the Office of Securities and a few other organizations to offer what's called the Senior Safe program. And the S in safe is a $. I think that's trademarked, but so we offer that program at a few different levels, both to frontline staff of financial institutions as well as to management. And it typically is something like a half-day training. It specifically covers a lot of the Maine banking laws so that folks can understand their authority, that they have the ability to report to groups like Adult Protective Services, because I know there are some concerns about how those laws interplay. So we offer that training, and a lot of financial institutions have engaged with that over the past few years. And like I said, I think in part based on some of that work, we've seen an increase in the number of reports that we receive from banks, even though they're not mandated reporters in Maine. They are they've got a great sense of what's going on with their customers. And then with respect to other groups that are non-mandated reporters, we do offer kind of trainings. I will meet with groups on a regular basis to share information about Adult Protective Services. And we offer a mandated reporter training through the DHHS APS website. So you don't have to be a mandated reporter to take that training, but it covers some of the same topics here in a little more depth, what we're thinking about when we talk about examples of abuse, examples of neglect, and examples of exploitation.
So we still have another question or two. Do you want those now, Erin?
Sure. Yeah,
So-
that's all my, I can unshare screen so we can have a little more of a conversation, but just so folks are aware, this is my phone number and my email address. I'm always happy to address questions that come up around Adult Protective Services.
Great. So this one is, how has the move to supported decision-making model in the state for children with disabilities transitioning to adulthood affected what you see with at-risk adults, or is this a little too early to see any impact from that?
I would say there's been a lot of progress made in Maine around education about what is supported decision-making, particularly focused on clients with intellectual disability and autism, making sure that folks are aware that the second someone turns 18, they don't need to have a guardian necessarily if a team might be able to assist someone in making their own decisions. So again, it's just another another tool that can be relied upon to avoid the need for something like a formal guardianship. And I think that it's good news. I mean, I think that having the ability for folks to make their own decisions without that formal court-appointed guardian is something that we're glad to see happening more and more.
Erin, somebody asked if you could drop your contact information into the chat box.
Yep, I can do that.
Thank you so much. There's another question here about, do you have connections or conduct trainings with state hospitals for older inpatients? For example, a scenario where an older person is being financially or physically abused and then becomes an inpatient for mental health reasons.
We do, and of course, many hospital employees are mandated reporters. So we offer trainings and are in regular contact with a lot of hospitals about some of those clients. We also, for several hospitals, some of our district office APS supervisors have regular meetings with hospitals particularly to talk about clients where there might be a need for public guardianship. But that is a frequent report source, hospitals around the state.
Thank you.
So, Erin, we're always interested in how we can better prepare the workforce, both from the educational stance of folks who are training in the workforce, as well as training once they are in the workplace. So how can we do a better job? No big deal. Just tell us how to do it.
No, I think it's in some ways a tough question, but and maybe I should set my sights higher. But I always say if people know that Adult Protective Services exists and they know the circumstances under which they should be contacting APS, that's my number one hope. I think that these are really difficult situations, and it can be a very tricky call to make. Particularly, it's that concern that it's going to impact the relationship with the individual that you call about. So I should mention, when someone makes a report to Adult Protective Services, we take the confidentiality of reporter information very seriously. So we do not disclose to an individual who made a report. It's not uncommon that one of the first questions that's asked when we arrive at someone's door is, who sent you here? We don't answer that question. And there are only certain situations where we do disclose reporter information. So if law enforcement may need it, if a court orders us to disclose it as part of some litigation. But that's never a part of a conversation that we're having with the client about who made a report, which I think is an important piece to keep in mind.
I just want to mention that we have put together a resource document that is accessible to everybody, and Tiara will make sure that information gets in the chat at some point as we proceed forward, but it's a really comprehensive resource list. But I know we have some people here, Erin, from other states, and I'm very curious, because we're speaking from a Maine-centric perspective here a little bit, whether anybody would like to either enter the chat or make a comment about what might be similar or different in their city or state. And then we'll wrap up.
And I do see one other question that's come through in the chat. What a rough percentage of reports that are initially made to those that are adjudicated in some way. And I'm in terms of what exactly the question is, I'm wondering if that means like prosecuted versus us making a determination that, yes, we believe there was abuse, neglect, and exploitation. So I'll try to answer both of those. So typically, if something is assigned to investigation, we see around a 50% substantiation rate across all of our different types of allegations, but that can include that includes every abuse, neglect, and exploitation, including self-neglect, which is kind of another category that we think about, particularly if someone is experiencing some cognitive decline or is unable to meet their own needs that they maybe were able to meet in the past. And then in terms of how many cases are initially reported to Adult Protective Services that are ultimately prosecuted, unfortunately, we don't have that data yet. It's something that's kind of on the wish list of something we would like to see a little bit more. Our timelines of when we initiate an investigation, work with law enforcement, and close the case typically happens a little bit more quickly than the full process for the criminal justice system to play out. And so we don't kind of have that circle back mechanism to understand which cases were ultimately successfully prosecuted or pursued at a criminal level at all. So hopefully someday we have a better sense of that, but currently we do not.
And I want to thank Jody for sharing a link for Massachusetts services. Thank you very much, Jody. Do you want to add anything to that? You're welcome to say something. Light up your square here. Nope. Okay, that's fine. So we have resources for Massachusetts. Oh, Jody cannot unmute. Can someone unmute Jody? Is that a possibility? Nope. Tiara, do you know if anyone can unmute Jody?
I think I'm all set.
Oh, good. There she is.
Hi, everyone. My camera's not working, so I apologize. Yeah, I just wanted to share for Massachusetts. I know Maine and Massachusetts are always have resources that cross over, so in case it's helpful.
Great, thank you. All right, well, Erin, are you wanting to give us you did a nice job of taking us to the next conversation about crime and especially healthcare crime, but is there anything you want to do before we transition, say to our audience?
Thank you all for being here and for the work that you do to support older adults. I will put my contact information in the chat momentarily. And like I said, please don't hesitate to reach out if you have any questions. I'm always happy to touch base.
Thank you, Erin. It's my pleasure to introduce our next two speakers. We're really quite excited to have all the speakers today. And the next two folks are John Burke and Heath Langevin. John's been a practicing lawyer for a little over 25 years, and the last 17 years as a prosecutor, first in DV work and now in healthcare crimes at the Attorney General's office. And Heath, in his 18th year of law enforcement, has worked in a variety of areas, patrol training and as a detective, and he's currently working as a detective with the Office of Attorney General and Healthcare Crimes Unit. So these two folks are really have some, I think, some really interesting and important information for us to hear. So please welcome John and Heath.
Thanks very much. And I'll just start our PowerPoint here as we chat. As mentioned, I'm a prosecutor within the Healthcare Crimes Unit of the Attorney General's office here in Maine. And with me is Heath Langevin, an Attorney General's detective, also working in healthcare crimes. The Healthcare Crimes Unit is what's known as a Medicaid Fraud Control Unit, an MFCU or a MFUCU, if you have total confidence in your enunciation. We're a federally and state-funded agency within the Attorney General's office. And we investigate and prosecute primarily two kinds of cases, fraud and waste in the Maine care system, so primarily financial stuff, and then abuse and neglect of patients who receive Maine care or in facilities that receive Maine care, which tends to be...
The slide is a little funny. It's small. I think, unless that's just me. Shelley, are you seeing that?
Hey, John, your notes are up, pal. Just want to let you know.
Yeah.
Oh, okay, thanks very much. I am going to try to share. How's that?
That's great. Perfect.
All right. Thanks very much. We take in referrals from a great variety of sources. We investigate cases that show need and promise. We prosecute cases where appropriate, and we refer cases for downstream review by state and federal regulatory, civil, and criminal authorities. I'm required by federal law, by the Stevens Amendment, to tell you in terms of sources of funding that the healthcare unit receives 75% of its funding from the US federal government through the Department of Health and Human Services, and the remaining 25% is funded by the state of Maine. And finally, while Heath and I are fairly reasonable people, we don't speak for the Attorney General or the Healthcare Crimes Unit, although again, they are also very reasonable people. Today, we're going to start by talking about the process of healthcare crimes investigations. I'll talk about it in general. Heath will talk about how he would investigate today's case based on what we know so far. And then I'll talk a bit about criminal statutes that we use to prosecute bad behavior by healthcare providers. And we use offenses of general applicability. We don't have special criminal statutes to cover the provision of healthcare. And that means that, the same assault statute that we use to prosecute a bar fight or any other kind of, common assault is also used for things as specific as unconsented to treatment by healthcare providers. And we can talk a little bit about the wisdom or lack of as we address the assault statute of that kind of system. I just ask that if you would ask questions as they come up by putting them in the chat. We'll be monitoring that and I'll pay attention. But if any co-host wants to unmute and let me know that a question has come up, I'd prefer to deal with them as they come. So at the outset here, first off, our process. So in general, we work much like any other law enforcement agency. We take in reports of suspicious or criminal behavior, and we triage them to determine whether we or another agency should respond and either investigate, refer to another agency like APS.
Did you mean to drop your PowerPoint?
I did.
Okay.
Yeah, I just for my explanation of the process, I don't have a slide.
Sorry to interrupt.
No, not at all. Thank you. And I'll appreciate your sort of riding herd on my PowerPoint for obvious reasons. And we'll refer to DHS as fraud entities, licensing, or another law enforcement agency if we think a crime has been committed, but it's either not within our bailiwick or we just don't have the resources, or we'll take no further action. For cases that we decide to investigate, one of our detectives, well, like Detective Langevin, who's here today, will work with the prosecutor to develop an investigative plan. They'll head out and work it like any other case. They'll talk to victims or witnesses. They'll review clinical and financial documents, execute search warrants, and then if probable cause is developed to determine that a crime has been committed, they'll work with their prosecutor to determine what offenses to charge and how to proceed. At that point, we'll either give somebody a summons, essentially a written invitation to come to court and answer the charge. We'll arrest them immediately if the offense occurs in front of a detective or we have probable cause to believe that a felony was committed, or we'll seek an arrest warrant. Basically, we just tell a judge what happened and ask him or her to issue a warrant. At times, we proceed directly to grand jury, which is just presenting the facts to a grand jury through typically just detectives' testimony. And if they believe that probable cause exists to believe a crime was committed, they'll indict that person and have them summoned or arrested. Once charged, we'll typically seek bail conditions, prohibiting them from having any contact with any victim, if a victim of the crime is out there, from using illicit or non-prescribed drugs if substance abuse was a factor in the case, and from providing healthcare or personal care services during the term of the case if appropriate. And then the case just moves through the criminal justice system. A defense attorney will be hired or appointed. The prosecutor will develop a plea offer, typically in consultation with any victim or representative if they lack capacity, and the detective. And we'll try to work out the case by agreement. And in fact, almost all of our cases work out by agreement of the parties and ultimately approval of the judge. And that's true of almost all cases in the Maine criminal justice system. We'll seek rehabilitative conditions in most sentences, patient safety, education, community service, and whatnot. But in some, we'll just seek straight jail or a fine. And finally, we typically seek to exclude from participation in federally subsidized healthcare anybody convicted of a crime that touches on healthcare. That's a process by which the federal DHHS will bar somebody from working for any employer that accepts federal funds, which in fact, in practice, tends to exclude somebody from participating in healthcare, as so many employers in our state are federally subsidized in one fashion or another. It tends to be a prohibition on continuing that kind of work. And then finally, we'll make appropriate referrals to licensing and supervising agencies and boards. And with that general overview, Heath, do you want to talk a little bit about how you would respond, how the unit HCU might respond in general to the Bogosian fact pattern as we know it so far?
Heath, if you don't mind, there's one quick question there, John. Would you refer a crime to be determined a hate crime to a different entity, or do you handle those as well?
Yeah, great question. There is, as noted at the outset, there is some overlap in that sense. So it depends a little bit on what I guess we would see as the primary heart of the case. In general, once we take a case, we tend to have, once we take an interest or have jurisdiction over a case, we tend to have better resources to investigate and prosecute it. We generally have fewer cases, our detectives and investigators, and so we can spend more time on it. So something that would require a nuanced addressed by the public justice system is going to get more attention from us. So in general, if it's between us and another agency, we like to take it if we can. That said, hate crimes are a fairly specialized subset of civil and criminal justice, and we have a specialized unit in the Attorney General's office that investigates and prosecutes them. We would probably, in this case, either refer it to them because of the special tool set that they have and experience, or split the case up where we would take the healthcare offense and the civil and criminal unit that handles hate crimes would handle their piece. Great question, thanks.
Great, thank you.
Thank you, John. So when it comes to this particular case that we heard at the outset of this presentation, I just wanted to run through some of the facts that I saw pop up that I would look into if we were to get a referral just on what we saw from the very beginning. So we know that there's some unexplained bruising. He's asking for more medication, and the caretakers are always within earshot. And those are some flags that would certainly rise up on my flagpole to look at. And then the other piece to this is he is of sound mind. So Mr. B is of sound mind. So that's gonna weigh a lot into this, because when I come to interview him, if he can explain all of those things away, then there's that's it. That's the end of the investigation. But if he starts to open up on that, then we'll dive further. So right away, those are the things that stuck out to me with this case. So if I were to get the case handed to me as it stands right now, I would obviously interview whoever the referring party was. The caretakers would be right up there if they were the ones that referred it, or if it was his sister or whomever. The caretakers, and then Mr. Bogosian himself. I would sit down, and when I sit down with him, it would be without the caretakers and without family. Probably I would like to do it just me and him. That way he can feel free to open up about whatever's bothering him. If through those interviews things came up that continued to raise questions for me, I would request medical records and go through his records. Our unit is essentially, the easiest way to explain it is we're kind of exempt from HIPAA. So I can get in and review his medical records unredacted and read through all of those and see what's popping up. From there, if I still had suspicions that things were going on, I would likely, I work very closely with John or the other prosecutors in the office. So I'm always communicating with them, and I would tell them where we're at on the case and update them to see if it's something that we're going to take to a criminal prosecution or not. But as it stands right now, with the case that you've heard already, this likely would not lead to a criminal prosecution because there's no crime that has been spelled out as having been committed. There are certainly red flags and there are things to pay attention to, but as of yet, we haven't heard anything. So for me, what I would tell the call taker or the person that's calling in the report or the caregivers is you have some suspicions, so continue to watch for those, continue to pay attention. In these cases, with what's spelled out already, I would obviously be concerned about assault with the unexplained bruising, and that would have to take somebody either witnessing it or Mr. B telling somebody that he was assaulted. I would look for drug diversion. If he's asking for more drugs, it could be that he's not getting all of his prescribed medication to take care of the pain. So there's some concern there that maybe he's not getting what he should be getting, and where are those drugs going? And then I would also look into endangering the welfare. Is there a reason why all of these things are happening and endangering the welfare of a dependent person? So I would tell the caretakers and the sister and family to be on the lookout for these things if I wasn't able to prove up any criminal allegations. But as soon as a solid allegation came in and we were able to prove one of those things, then we would step it up to a criminal prosecution.
Heath, we had a question. As part of your record investigation, do you have access to Adult Protective Service records as well?
Yep. So we work very well with APS. There's been oftentimes that I've gone directly with Erin herself or some of the supervisors that are right above the investigators. I'm on the phone with them probably weekly, going over reports and things of that nature, and I will get those records as well.
Great. And then a follow-up, what about the substance abuse treatment, which is more protected under HIPAA? Do you also have access to that?
In some respects, yes, I do have access to those. They are very well protected, and we have to get a court order for me to be able to view them. And there's very strict lanes that I have to stay in to see those. But in certain cases, yes, with a court order, I can view those.
Great, thank you.
And so with that, we'll jump into talking about some of the statutes that are implicated. As I say, these are statutes of general applicability, but we'll talk about how they work themselves into healthcare inflicted offenses. And I'll try and share that. So starting with assault, and Heath, please jump in at any point if any of these sort of are either particularly relevant in this case or you think that any of our cases that we've worked on together are relevant to mention. So assault comes up primarily in many of our cases, and it has a number of flavors. And we're going to use this as an exemplar to talk about how criminal statutes work and what it means for the state to bring any of these offenses. So these crimes are made up of elements, and the state has to prove each element of the offense beyond a reasonable doubt. So say in a case like the Bogosian instance, if we have bruising, if we have report of somebody mishandling a healthcare consumer or patient, or then we would be looking to prove these things if we wanted to charge an assault. In the first instance, we have a mental state that we need to prove. We need to prove that the offender committed the act intentionally, knowingly, or recklessly. Intentional would be that they intended the consequence. Knowing that that would mean that they knew that it was almost certain that the consequence would result. And recklessly means that they disregarded the risk that the result could happen, and we'll talk about those in a minute. Causation we'd have to prove, and then the result that would have to be proven, which is either bodily injury or offensive physical contact. In Maine has a fairly low bar to charging assault because the recklessness component, unlike a lot of states where recklessness is tied only to bodily injury, can apply to offensive physical contact as well. So if you take intentional conduct, intending that bodily injury would result, you punch somebody in the face, that's a fairly obvious assault. That's the sort of standard high level assault. But recklessly just involves the disregard of the risk that it could result. So, you would have to know that the risk was out there, but not necessarily intend it or know for an almost certainty that it was going to result. So closing your eyes and spinning around in a crowd while wielding knives is reckless with respect to the result that bodily injury could result. But it also goes to offensive physical contact, which is to say merely contact that does not necessarily cause bodily injury, but which a reasonable person would find offensive. And that reasonable person standard means that the victim's subjective reality, their subjective experience of the contact is relevant but not controlling. So if, say, one healthcare provider saw another coworker's contact as regards a patient or a resident or healthcare consumer and found it to be objectively offensive, that could carry the day irrespective of whether the victim of the contact themselves found it offensive. And we've got some of the penalties up there. More relevant are the defenses. So defenses to this can include competing harms, which basically just provides that the the harm actually caused by the conduct is outweighed by the social value of the conduct itself. This is a catch-all. I think a healthcare provider would never want to find themselves on the using end of this defense. You'd have to establish that the desirability and urgency of avoiding the harm caused outweighed the harm sought to be prevented by the statute violated, and it's a difficult defense because it's so squishy. I think a healthcare provider much more likely wants to find themselves being defended by either consent of the would-be victim, the putative victim, which with a person who lacks capacity would be the consent of their guardian or decision maker. And it should be noted the injury threatened or caused by the act, which is allegedly consented to, must be foreseeable, and the person who consents must give what's known as an informed consent. So they have to know the consequences. They have to know the full sort of boundaries of what they're agreeing to and the risk posed by it. But by and large, healthcare providers are protected by the defense of use of force by persons with special responsibilities. It has some moving parts to it, so it pays to know them. I think an imperfect defense negates the defense. And so, unless all of the terms are complied with, like under consent, if the consent is not fully informed or it's imperfectly given, negates the defense of consent, and then we're back in the world of an assault having been committed. So under persons with special responsibilities defense would have to be a defense employed by somebody who was either a physician or working under a physician's direction, was administering a recognized form of treatment, reasonably believed to tend to safeguard physical and mental health of patient, and you either have to have the consent of the patient or guardian, or in a health emergency, have no opportunity to consult. And it has to be the case that in that circumstance, a reasonable person would consent.
So a couple of good questions. Are you ready for those?
Sure, shoot. They're
related to assault. One is, can you talk about the difference between assault and battery in the state of Maine, and specifically in relation to healthcare settings?
Sure. This is a great question that obtains in primarily in other states with, I guess I would say, more old world or common law statutes. I believe, and this is going back 25 years to when I took the bar exam, because we don't have this distinction in Maine. And Erin, who's more recently having taken that, may chime in and correct me here, but I believe that assault was putting someone in apprehension of an imminent physical contact, whereas battery was actually causing physical contact. And so in Maine, what we have are a couple of statutes that go to threats and apprehension of a victim of contact, like criminal threatening and terrorizing. Criminal threatening tends to be a little bit more in the sense of causing that apprehension, and terrorizing tends to be more the verbalization, enunciation of a threat, loosely. And in Maine, we only have assault. We don't have battery. And assault encompasses the things that we've talked about. So that distinction has somewhat gone by the wayside for, I guess I would say, more modern instantiations of the assault statute. But the distinction used to be between the apprehension, causing the apprehension of the contact, and then the contact itself.
Great, thank you. And we have a question related to COVID. Are you seeing since the COVID pandemic that victims may be less willing to cooperate for fear of increasing their isolation?
That's a good question. You know, I haven't, but we don't have a lot of great information about, really data-driven, more than anecdotal information about COVID's impact on our work, and or in this instance, the question about victim cooperation. The fact, though, is, and this is the heart of that question, and what makes it a good question is that we have concerns about that. We've had people who've been isolated from the outside world and have had less oversight into sort of the care that they're being provided with as a result. So that's a concern. I think we have a pretty good track record of protecting either whistleblowers, peers of an offender, other healthcare workers who call out the behavior of a peer, and victims, their families, and other folks who are sort of very directly in the way of a badly behaving provider. Heath, have you found that probably COVID has affected your interactions with people a great deal, but have you found any issue of cooperation due to this question, the fear of increased isolation?
Yeah, although COVID has certainly restricted my movements, particularly with going into nursing homes and things of that nature, I've found that there's still, when I get a complaint in and call the person or have a Zoom session, they're still very much willing to talk. I think if they've made that determination that they're going to talk irrespective of what COVID was going on and how it's affecting them. So I've really seen no difference in that, except that I'm not able to go see them in person.
And Heath, Frank Brooks just asked about the effects of the pandemic on your process. How has this changed your process of investigating allegations of abuse and neglect in nursing homes?
Yeah, so certainly it's changed a ton. I used to walk right into a nursing home unannounced if I got a complaint, and walk right up to the room that I needed to go, or go speak with the Don or the administrator immediately and get their side of the story, and then go see the victim or potential victim. But with COVID, we've taken ourselves out of the nursing homes. I didn't want to, we had special regulations, that we would have to go in if we had to, and I haven't had to take it to that level. So I've had to do everything over the phone or through Zoom or other entities like that. And we've certainly seen less complaints come in, just as Erin mentioned with APS, that certainly has dropped. But aside from that, nothing else has really changed for me.
Thanks. And so with that in tow, that sort of discussion of the assault statute, I want to move into some more general statutes that we use from time to time. Here's some information about the culpable states of mind that I think we've already covered. Intentionally means intending the given result. If I wait for somebody to walk by on the sidewalk and I drop a piano on them from the 4th floor, watching it strike them and intending that I do so, that's intent. If I see them coming and then drop the piano, knowing that it's likely to, but not necessarily intending it, it's a little bit of a fine distinction, but I might lack the intent, but know that it's going to happen to a practical certainty. Recklessly would be, not looking out the window and just throwing the piano out the window and disregarding the risk that it would strike somebody. Criminal negligence, we don't tend to use much. It does come up in some manslaughter situations. And it's just failure to be aware of a risk that the conduct would cause a given result. This can sometimes come up with a provider that plausibly claims to not know that their conduct would cause a given result, but we think that they should have known. As I said, the defense is competing harms. Is not a particularly useful defense in this setting. We prefer that folks get consent or act under the special responsibilities statute, which is specifically geared towards healthcare providers. And then the assault scenarios that we see, we'll see bodily injury. Say in the Bogosian case scenario, we saw bruising, and we had one of the staffers or the nephew say that the other party had grabbed Mr. Bogosian forcibly. That would be bodily injury caused, perhaps knowingly, perhaps recklessly, but it would meet the standard bodily injury. We've had a nurse punch a patient. That's a standard bodily injury case. Offensive physical contact we have from time to time. We had a personal aide that repeatedly sort of put her hands on residents of a group home in what normally might be some people are touchy-feely, right? So it might normally have just been a comforting gesture, reaching out to make a personal connection with somebody. But the residents repeatedly asked her to stop it, and repeatedly sort of recoiled from her touch, and made it fairly clear, including a couple of instances that were on video, that they didn't want to be touched. And the contact did not cause injury, but it did cause offensive physical contact. And we charged her with several counts of assault. And then finally, more complicatedly, imperfect consent. So in cases where a provider provides what is, I think, generally standard care, accepted as the standard of care, but that care is provided without perfected consent that is withdrawn, consent that is given by somebody without the authority to give it, then that contact that results from that is an assault, because they can't use the defense of consent, and usually at such times the defense of conduct by persons with special responsibilities is not present, so it's not an emergency. And so most often we see that in cases of substituted judgment, a provider who thinks they know what is best for a consumer and chooses to enact that without actually getting perfected consent. Before we go on, I'll see that we do have another question, and I will give you a case of imperfect consent. That's unfortunately a fair amount of our docket these days. So investigations of DV have changed since the pandemic. I've been out of DV for about 5 years now, and that tends to be investigated by local police agencies and prosecuted by local prosecution agencies. That is to say, district attorney's offices. I can't think of a single domestic violence case that I've taken since coming to the AG's office. And so I'm a little bit out of touch with how that is being investigated. Heath may know because he's in closer contact with local investigative agencies, but I think you'd find that investigations are still ongoing, that most agencies are putting their investigators out there in the world. They're using PPE as much as they can. I think we tend to think that we're getting fewer reports of this than are occurring, even though I think we're getting a smaller percentage of the actual cases reported than we used to get, because we didn't used to get all of the cases reported anyway. But I think we're getting an even smaller number of those by virtue of the isolation and the fact that DV cases are so complicated by the relationship between the parties. That relationship is even more central to a victim and more omnipresent in their lives than before quarantine and lockdown. Heath, do you have any insight on that?
No, not really. I've been out of the DV game since coming to the AG's office. I know that it's it's a problem, and there's still my friends with the local PDs are doing everything that they can to respond and deal with it. But me personally, I haven't dealt with it.
Yeah. And I think, like the earlier question about victims fearing further isolation in our setting, we have victims that are not in fact and don't feel safe to reach out to law enforcement in this setting. And probably investigations are down, which is to say investigators are at times probably hindered by the current public health crisis.
I would just like to jump in for a second
Yeah.
to let you know that we have about 3 minutes before the break. I just wanted to give you a heads up.
Oh, thanks very much. And so I'll cover briefly imperfect consent. We have a couple of instances recently where we have had people who've had guardians. One guardian gave consent initially to a treatment being provided to a child. The consent had conditions. So the consent related to a process. I consent to you giving this treatment under these circumstances. Subsequently, when those circumstances were not at play and those conditions had not been met, a single provider tried to administer the theoretically consented to treatment. Because those conditions hadn't been met, and because the treatment went completely sideways because of that, we investigated that as an assault. I believe it was an assault. And it was just substituted judgment, kind of like, well, in any case, they substituted their judgment for that of the patient and the guardian. Similarly, another case where a patient had capacity, was not formally determined to lack capacity, objected to a given procedure. It was a cleaning. They had urinated, and the providers were in the process of cleaning her when she objected to the procedure. And there was no question but that she had the authority and the capacity to object. Despite that fact, the cleaning continued over her objection, and it's an offensive physical contact at that point. It was an assault. So those are imperfect consent. I think we can breeze through. We've covered criminal restraint is restraining another person, either physically restraining or confining. Consent is a defense. Endangering is our catch-all. So endangering the health, safety, or mental welfare of a dependent person. We use it in almost all of our cases where we have a dependent adult. Doing it recklessly is a Class D, what we used to call a misdemeanor, and doing it knowingly, which because of the increased information possessed by healthcare providers is usually a play, knowingly becomes a Class C or a felony, what we used to call a felony. Falsifying records, either general financial records or healthcare records, is a misdemeanor in Maine. Theft comes up in our cases quite often, whether it's money or drugs, but stealing drugs also can be, again, a felony. We see this in diversion cases most commonly, and we can talk about diversion if there's time. It's something that profoundly impacts the mental and physical wellness of patients, and we see a fair amount of it. And we like people in your position, who are in the world of healthcare, watching your peers do this work, to be on the lookout for a number of reasons.
Thank you, John, and thank you, Heath. And we can some of these, if folks still have some things, we can come back to them when we go to a panel a little bit later. Meanwhile, we are at a 5-minute break point, and when you just like you to know, when you come back, folks, when you come back to the webinar, we'll be showing the second part of the interactive case, and then giving you a chance to get in small groups and meet each other a little bit and talk about a few things. So thanks to everyone who've gotten to this point, and enjoy the 5 minutes. We'll see you back here soon.
hospice home visit, Carla called to cancel the hospice home visit.
I don't really understand why Carla doesn't want Johnny to see providers. They're so kind. And Johnny, he's so isolated and withdrawn.
Concerned about her brother's welfare and against John's wishes, Ramilla calls the hospice nurse.
I'm not sure what's going on at the Bogasians, and I don't want to assume the worst, but after listening to Ramilla, I think he have an obligation to report observations to Adult Protective Services. What do you think, Donna?
I have to agree. I mean, we're mandated reporters, but I worry if we do report, John won't have us back. I think he's really afraid of Carla and Pauline.
After discussion with their supervisor, Donna takes the lead on a call to APS.
I got a call from the hospice nurse caring for Mr. John Bogosian. They had enough information for me to visit the home, but when I got there, the home health aide, I think her name was Carla, she was very polite and let me in. The house was neat and orderly. The patient was asleep, and his sister didn't say much. She did offer cookies. There was nothing I could report, though I had suspicions, but I closed the case for now.
What could I say when Carla was watching me? She told Celia that John gets agitated and occasionally needs to be restrained. Nonsense. My brother's scared to death, and he's in so much pain. I think someone is taking his medication.
A week later, a 911 call is made to the police from the Bogosian house. When they arrived, they found Mr. Bogosian in extreme pain and his arms bruised. When Ramilla went to retrieve his medication, it was gone from his hospice kit. Carla put the blame on Pauline, who said she was selling her grandfather's drugs. APS was called back to the home for further assessment.
Okay, so what we'd like you to do, we're going to break you into breakout rooms for this. And what we'd like you to do is introduce yourselves to each other and say a little bit about where you work and who you work with, who your population is. And, you know, you can share your interests in this content. And make sure that someone in your group is willing to take notes or be willing to report out when we come back. And here are the prompts. And I always say this, you know, if you get deep into one of these questions or prompts, don't feel like you have to cover both of them. A deep conversation, a meaningful conversation is what we're going for here. So the first is discuss the tension between autonomy and decision-making for older adults in terms of safety considerations. So how do you balance that sense of Mr. Bogosian's, you know, individual dignity, his autonomy, his decision-making capabilities, and the fact that he appears to be in an unsafe situation. And the second is to consider your role with Mr. Bogosian and others in his situation that you may be working with now or in the future, and what factors would influence your decision-making choices. So how would you think about care? How would you think about intervention? And I'm just going to throw a little side, my colleagues don't know I'm going to say this, but also if you have a moment to reflect on what it's like to work in a field where it's very hard to have direct access to make interventions because of consent, because of situations. How would you feel about the many cases you're not able to intervene on? Tiara, are you putting people in breakout rooms now? Would be willing to share what came out of their group and talk a little bit about, you know, we talked a lot about the ethical quandaries that were presented to us in this case, and the fact that the frustration of having to wait for something really bad to happen before one could intervene. I'm wondering if anyone from Molly or anyone from that group would like to talk about that.
We had an interesting discussion on the first question and sort of talked about some examples from our own work of navigating the system the client-driven system when we don't agree with the client's decisions necessarily, and how hard that can be. I don't know if anyone else wants to chime in from the group.
I think, thank you, Kayla and Bobby. I think the group did a really in-depth look at that tension. And Brittany was talking about a case that she had written about in a paper for the aging class with regard to how difficult it was. Well, actually, Brittany, would you like to bring some of those issues forward?
Sure. So I used to be a child protective caseworker before I started my my new role, and I remember one of the investigations I was completing was a report that was referred over from APS. APS had received the report initially, and then they had gone out to the home and determined that a report to CPS should be made. So we're kind of doing our investigations alongside each other. But really what we were taught, like this case really spoke to the first question, where the older adult in the home, who wasn't my client, because my client was the child, but the older adult in the home knew what the concerns were in the home, and the concerns were around neglect for the child and the older adult due to the home environment being unsanitary. And the home environment was, in fact, it didn't rise to the level of being unsafe, but it was very close. But the older adult was aware of the home environment and was provided a lot of support, a lot of education, the opportunity to, have an out-of-home placement, so be somewhere else. People were really wrapping around him, and he chose to stay there. And he chose to stay there time and time again. It was just challenging for me, but also, challenging for APS. And we were talking in our group about how for my paper for Frank, I was able to interview an APS supervisor. And he really spoke a lot about how challenging it can be for supervisors and caseworkers in APS to kind of handle that, to know that it's their client's choice and it's their right to make that decision, but also to know kind of the situation that client is left in. So that's kind of what we talked about. I hope I summarized it well.
We have a lot of, I'm looking at the discussion in here and we have a ton of it. Tom Muser said, Group 6 pondered the question of when do you intervene to help an older adult in a potentially, and I think, that is sort of the crux of some of the questions here is when do you make that intervention, given that it's adults who are cognitively competent. I'm curious, Tom, from your vantage point as an expert in aging and health, what have you seen with that, with clients who are perfectly competent, would not ever, need to be determined incompetent, but when do you intervene and how do you manage those situations?
Yeah, it's not an easy one. I think we have to be careful about being ageist with respect to our perceptions of persons' integrity to make their own decisions. And unless somebody is deemed incapable, you have to assume capability. And that means allowing people to make bad decisions sometimes, or decisions we might not agree with. That can be within a family unit, or it can be among professionals who provide services as many of us are here. Sometimes I think you kind of have to build an evidence history, and there needs to be sort of a weight of evidence to show that something's going on before one ventures into taking away that independence or raising the issue. I mean, where you draw the line can be difficult, though, and I don't have a great answer there, except that the ageism issue, I think, is one we have to be really careful of, not to jump to too many conclusions too fast.
Yeah. Maddie Welch's group spoke to those issues as well and came up with really focusing on what resources can be offered. How do you bring resources in so when people feel that they're ready to access them, they're there, they're easily accessible. And the other thing I really like in this comment is being honest and naming one's concerns about the situation, not colluding, not, but at the same time, respecting human dignity, respecting, a right to make whether they're bad decisions or good decisions. So I don't know, Maddie, whether you or anyone in your group wants to add to anything with that.
I'm not in that group, I'd love to add something after if that group decides they would like to add something.
Well, why don't you go ahead, Bobby, and then if anyone in Maddie's group wants to jump in, that would be great.
So just thinking about like the second question and the case we've been presented with, and I'm sure Stephanie, when they give their talk about substance use, can maybe correct me if I'm incorrect, but just the research that I've done, because my placement is in a hospice setting, and just knowing that older adults, there's a higher rate that they may have experienced trauma, and particularly when they are in a hospice or palliative care setting, that trauma could have been induced by some sort of medical intervention. And the research that I've done has shown that when one has experienced trauma, they experience higher levels of pain, so they might need more medication to alleviate that pain. And also, folks who have been living with substance use in their past also require higher medication to manage their pain. So I guess just to throw that into the mix, that higher levels of morphine or whatever their pain management medicine might be could be a result of trauma they've experienced, or if they have previous substance use in their past.
Which I think, Bobby, adds, again, another whole dimension of complexity and the need to make sure one is not jumping to conclusions about one's medication use.
Mm-hmm. Yeah, really great points. Not jumping to assumptions, period, but being diligent about following the evidence, so to speak, and making sure you're staying in connection. I see, Molly, you have put some stuff in the chat. Would you like to chime in?
Shelley, you keep putting me on the spot here.
I know.
I'm about to graduate, so yeah. I mean, we were talking about just like the ethical quandaries, struggling with having little proof. What do you do there? I think in this case in particular, our group was talking about the sister's role and how she could be a good ally, but there's still some ethical stuff around there. And then, it's talking about ageism and the value that we place on older adults in our society, and how, and we were saying, we can't make this a blanket statement because we have so many different cultures in the United States, but the value of independence over community, and how that can be really hard when you're trying to work with someone who does have autonomy and is really holding on dearly to that sense of independence.
Great, thank you. We have here from Stephanie Worth. Stephanie, do you want to comment on what's in here? It's very powerful.
Sure. Yeah, we talked a lot about the client-clinician relationship and navigating that as transparently as possible with clients, so that even though you might have to take actions from a mandated reporter perspective, that you were doing so with in an informative way and not in a secretive way. And we also touched briefly on like that might elicit a lot of strong emotion and response, and that it's sort of our duty as clinicians to take that and be understanding of that. And then we talked about, client wishes versus clinician perceptions of what the best solution would be, and honoring that there's a disconnect sometimes. And then we also focused a lot focused on how we could facilitate getting Mr. B in relation or in a conversation with either the investigator or his sister or someone whom he did have a better relationship with, to perhaps make progress in a way that was more autonomous, and how we might be able to help facilitate that.
Well, it sounds like we have some consensus around some of the issues, and I think our time is up, Tiara, for this session, but there's lots of incredibly great stuff in the chat if you get a chance to take a look at it. And I think I'm passing this on to Kelly.
Yes, so it's my pleasure to introduce Emily Barrow. She's an advocate at the Elder Abuse Institute of Maine. She's a graduate of the University of Maine School of Social Work. She graduated with her MSW in 2019 and has a background in intergenerational programming and legislative advocacy. And with that, I will turn it over to Emily.
Thank you so much. Let's see if I can successfully share my screen. Awesome. Yeah, thank you so much, everyone, for dedicating your Friday to be here with us. It's awesome that we have this opportunity to talk about elder abuse in this way. And thanks for UNE for inviting me to join you today. So I'm so excited to talk to you guys about elder abuse advocacy and the right to make decisions. I actually think this is a great segue into my presentation. A lot of what we discussed in the breakout groups has to do with what I've prepared. So this is awesome. So a little about the Elder Abuse Institute of Maine, in case you're unfamiliar with us. We work to address elder abuse in Maine through education, outreach, advocacy, transitional housing, and supportive services. So some of our programming includes our Martha's Cottage program, which is the first transitional housing and supportive services, specifically for older victims of domestic violence, sexual assault, and stalking in Maine. We have our Elder Service Connections program, which I'm going to go into a little more detail about through my presentation. This is the program that I work in. And this is a program that was created in partnership with Maine Adult Protective Services. We also provide outreach and education. So we do training and education throughout the state of Maine in collaboration with local organizations. So if you're interested in learning more about elder abuse, please reach out to us. We love to do training. And lastly, we just started a tablet program called the Elder Connect program for our clients to keep them connected during this time of COVID. And through that, we came up with the Maine Tech Task Force, which is a group of folks, including Shelley. She joins us every month to talk about technology programming and how to make the internet accessible for all Mainers. So if you're interested in joining that group, my contact is going to be at the end of this presentation, so please reach out. So I wanted to start with some values behind this presentation to give you guys some context while I'm talking. So the first value and kind of the premise of this whole presentation is that every older adult has the right to choose what they want their lives to look like. The second value is that there's no shame in accessing elder abuse education, resources, and services. The third is that age does not reflect diminished capacity or ability. The third is elder justice is holistic and every community member plays a role. And lastly, every person offers a valuable contribution to our vibrant and diverse community. So as promised, let's go a little more into Elder Service Connections, which is the program I work for. So the program was originally based on a 3-year intervention research project funded by the Administration for Community Living. So we work in partnership with Adult Protective Services. And at this time, the way it works is that referrals come to us solely from Maine Adult Protective Services in both Cumberland and Aroostook counties near the time of APS closure. So as an APS worker is working on closing out that case, they could refer to us. So we work with clients who may need a little more support after the case closes. We're pretty low barrier. Clients must be 60 years or older and at risk of abuse, neglect, exploitation, and/or self-neglect to work with an advocate. And our services are completely voluntary. There's no mandate to work with us. They can stop working with us at any time. It's really up to them. And then the purpose of the program is to support older adults who are experiencing or at risk of elder abuse and to address gaps in services. So we work from 4 modalities, which are motivational interviewing, teaming, supported decision-making, and restorative justice, which I'm going to talk a little bit more about restorative justice. And then we use a method called goal attainment scaling to create and track client goals. And on this note, goals can range from those related to the initial APS referral, so the reason why they were referred to APS, or completely different in another area of that client's life. It's really whatever they feel they need support with at the time of service. So we don't have to work just based on, if there's abuse involved or something like that. And we work with clients to create goals to ensure that our work is client-centered and client-directed. So going into goal setting and how that relates to the right to make decisions, as I mentioned, our work is client-directed, which means it's centered around the client's right to make their own decisions. And so the greatest support that we as providers and as family members can provide to the older folks in our lives is to uphold their right to make their own decisions. And so as we've kind of mentioned, I think in our breakout groups, I want to acknowledge that while this is the most supportive work we can do and support that we can provide, it's also some of the most challenging work we can do. And that's for a couple of reasons. The first is that if you're working with someone who may be in an abusive situation, that client may not be ready to address their abuse at the time of service. So just because an adult is reported to Adult Protective Services or has chosen to participate in a program such as mine, it doesn't mean that they're at a place where they're ready to make change yet. So, most of the time, as Erin kind of talked about, those referrals come from an outside source who's witnessing or seeing something, and it doesn't always, sometimes it does, but it doesn't always come from that person in the situation. So because services are being called upon by someone other than the client, it doesn't mean that they're ready to make change. So change will happen when the client is ready to make change. There's also the notion of safety, and that's super difficult to navigate because my definition of safety may be completely different than my client's definition of safety. So safety versus autonomy is a really difficult balance, and it doesn't always feel great when our definitions align. However, at the end of the day, my client's autonomy is the most important and something that I uphold when I'm doing my client work. Another factor is capacity, which Erin also touched upon, so I'm not going to go into too much about it, but I want to note that decreased capacity does not mean total loss of decision making. So just because an older adult may be experiencing maybe some memory loss or some confusion, or even has a diagnosis of dementia, there are definitely areas of their lives that they can still make decisions about. So that's also important to remember. And to wrap up this slide, I chose a quote from Being Mortal, which is Atul Gawande. And if you haven't read Being Mortal, I highly suggest you do. It's one of my favorite books and has guided me through my work. And the quote is this: "You may not control life's circumstances, but getting to be the author of your life means getting to control what you do with them."
So Emily, are you open to taking some questions?
Yes.
Okay, so we have a question in the chat that asks specifically about the scenario of Mr. Bogosian. When and how could he be incorporated into the Elder Abuse Institute for support, and looking at incorporating his goals, desires, values with a safe continuity of care and prevent the continued abuse and vulnerability current and present?
Well, somebody who asked that must have saw my next slide, because that's exactly where I'm going. So that's awesome. This is perfect. If John were a client, he would be referred to us. He would be offered the option to work with an advocate with elder service connections near the time of APS closure. So either the APS worker is still working with John and is moving towards closure for whatever reason, or they've closed and John would still like more support. And so if John agrees and would like to have an advocate work with him, then we would certainly be available for that. So as I said, all of our work is client-centered and client-directed. So when I'm working with John, we would work together to make goals based on what he wants at that time. So, John has the capacity to make his own decisions. So the goals that we make are directed based on what John wants. So I've come up with a couple of goals, which are real goals that I've worked on with clients in the past. But these are just kind of what John may want to work on. So for instance, advocacy with his hospice team, maybe some new in-home care options. He may want to explore legal options. Maybe he wants a protection from abuse order, or maybe he wants to learn about how do you evict someone or things like that. He may want some med management resources, possibly some socialization, meeting with other people outside of the home, or finding ways to bring other people in the home for him to talk to. And then there's the concept, which I think part of the question is about, which is like harm reduction and safety planning. So again, my goals are totally John's goals. And so if John's goal at this time is not to, it's really tricky. And again, this goes back to safety versus autonomy. But if John's goals are to address the abuse and the harm that he's experiencing, then we can create goals to do some safety planning there. And to find ways to prevent further harm from happening in the home. There's also this really cool part of our program that is not something we always see, but if John's goals are to help Pauline, which is, I believe, his granddaughter, and there's concern about abuse there. So if John's goals are, he wants to work with Pauline and help Pauline to get to a place where, she's supported and that aligns with Pauline's goals, I can work with Pauline to help her. So for instance, if she's interested in maybe rehab or case management, if she wants support groups or counseling or finding her own housing options, I can do that as well. And that kind of leads to the notion of restorative justice, which I will talk a little bit more about. But, if John had a goal of he wants to repair his relationship with Pauline, and that's at a place where John feels it's safe and it is safe to do that, there's not actively harm going on, then we can work on repairing that relationship or addressing the harm that's been done so that John, and Pauline can move on in whatever way makes sense to them. So I'm going to move on to talk about abusive relationships a little bit. And I first want to acknowledge that abusive relationships are super hard and complex and difficult to navigate for all involved. So the client themselves, the person who is doing the harm, and any team members who are involved, it's really tough. And that's because we know that in elder abuse cases, 2/3 of perpetrators are someone a victim knows and trusts or would expect to trust. So this means that family members and friends are at the top of that list. And these are people who the client may love and care about. And that's really tough because love and harm can be happening at the same time. Someone you love could be the one who's harming you. And so for that reason, we use restorative justice in our work with clients as both a framework and a formal process to support clients and their families to heal from harm. And so to do that, we work with the Restorative Justice Institute of Maine. We look to them to provide training, guidance, and to do formal restorative justice practices in circles when appropriate. So I would strongly suggest if you have more questions or would like to know more to visit their website, as they're a great resource. And so on that note, we know that abuse is often hidden, and I want to kind of focus on this statistic. As far as 1 in 24 cases of elder abuse are reported to the authorities. So again, as few as 1 in 24 cases of abuse are reported to the authorities. That's kind of a shocking number. And I think this speaks to a number of things. There are a number of reasons for why that is. But in regards to the context of abusive relationships, abuse is often hidden among family for a couple of reasons. One may be shame. So if you're an older adult and you're being harmed by maybe a child or a grandchild, there could be some shame around that. There could be some fear of losing family members and loved ones. So again, the person that is harming you could be the person that you also love. And so there may be fear of losing that person who you love, or people who are attached to that person. So if it's a child, you could be worried that you're going to lose touch with your grandchildren. And that could be really scary if you were to ask for help. There's that risk. There could also be some trouble identifying abuse. If it's occurring due to family norms. So if abuse is generational and it's something that is quite frequent in family dynamics, it could be hard to pick out from and to acknowledge that this is abuse. And then there's also ageism, which is a reason for why things go unreported. And I will go right into that as well. Oh, Kelly, I see you unmuted.
I was just going to say, we have several questions in the chat. So do you want to take those at the end, or do you want to take some of those now?
I could take maybe one now. I want to make sure I get through everything and have time to answer questions. So I could take one now.
Of course. So there's a question here that says, how do you navigate working with other occupations such as police or principal investigators who focus first on safety and not autonomy? How do you find a balance in these collaborations?
Yeah, absolutely. And that's super tough because, when you're working collaboratively with other disciplines, we each have our own job to do, and we each have our own ethics that we abide by. And so sometimes those can come in conflict when we're working together. And so the way that I view my job is I'm kind of an extension of the client. So as I'm working with other disciplines, my number one goal is to advocate for the client and their wishes and their wants. And so that's my driving factor in trying to collaborate with others. And sometimes it's tough, and sometimes, things happen that are out of our control, especially in terms of legal situations where a law has been broken and there's not really much you can do about that. So it's working with that client to kind of cope with the circumstances that are happening. So it's kind of case by case, but I, for the most part, all of the disciplines that I've worked with we all have a shared goal of doing what needs to be done to help the client. So there isn't always too much friction, but sometimes that does happen. Yep. Okay, so talking about ageism and how it interacts with elder abuse. And so we know that a likely cause of elder abuse is ageist stereotypes that depict older adults as frail, weak, and dependent. And so when older adults are depicted as these stereotypes, it can lead others to treat them as such. And so individuals who hold stronger ageist attitudes may be more likely to engage in elder abuse. And that could be because being perceived as low value or unworthy may allow others to mistreat older adults with little accountability or inhibition. We also know that ageism can be one of the reasons why health professionals fail to report elder abuse. And I think this kind of leads into the fact that elder abuse ageism can be externalized and also internalized. And so we see this in John's story. We see this this externalized ageism through one of the hospice workers. She says that John is quiet, but I have no doubt that he's all there and quite with it and responsive to anything we ask. And so my question, would be, what if John wasn't all there or quite with it? And what if he wasn't very responsive? Or what if he did have some cognitive impairment or dementia? Would those red flags, would those concerns still be there? And would there still be would they be compelled to report to APS? And so I think that can be a reason why sometimes it's not reported. And we also know that ageism can be internalized. So we hear John say when he's asked about his bruises that it's just my old age clumsiness. And so as we age and we hear stereotypes about aging, we can internalize those ourselves and start to feel that way about ourselves. So it's not just the way other people view us as we age, it's the way we view ourselves as we age as well. And so ageism also plays a role in decision-making. So again, we at the Elder Abuse Institute of Maine believe that every older adult has the right to choose what they want their lives to look like. But that's not always the case. That doesn't always get to happen for folks. And that can be due to a couple of reasons. And there are a couple factors that contribute to ageism surrounding choice. There are much more than I've put on this list, but for time, this is what I have. So we've already talked about stereotypes such as weak, frail, dependent. So if someone views you as weak or frail, or you're dependent on someone or something, perhaps your decision-making is being questioned. There's also capacity. So again, when someone may start to lose their memory or they're having some kind of cognitive impairment or something of that nature, decision-making is questioned, and so that can lead to that. Although I would like to say that capacity can fluctuate. And if you're interested in learning more about capacity, I highly suggest you do. It's a very gray area. It's very tough to navigate. And so the more education you have as possible can help around that. Also, physical health, mental health, and substance use, any challenges within these areas, decision-making can be questioned and maybe not taken seriously. And the last I put at the bottom, because it's one of the things I see really often, and a great example are falls. And so when older folks, maybe start to fall, there's this rush of those around them who care about them to jump directly to safety. And so how do we stop the falls from happening? How do we keep that person safe? And so that's really tough because it comes from such a good place of wanting to keep that person safe. However, that rush to safety often leads to looking over that person's wants and desires. So for instance, I've worked with a gentleman who falls quite frequently in his home, and those around him are very concerned about his safety and have pushed me to work on goals with him that include facility care. And we've talked about that, my client and I, and for him, he views facility care as a death sentence. It's not, but to him, it is. And so it's worth the risk for him to be at home and fall rather than to go somewhere that he's not comfortable. And so he has the capacity to make that decision. And so that's tough. Again, my definition of safety does not align with his definition of safety. And so it's really tough, but knowing that this is his choice and how can we support that? How can we do some safety planning and harm reduction around that to make sure that, you know, if you're home, how can we prevent falls at home? So that's huge as well. And then I also wanted to talk about reporting and decision-making. So reporting to Adult Protective Services, and it may seem a little counterintuitive to this whole presentation that I'm doing about choice and then reporting to APS. And I think that's because a lot of folks who are unfamiliar with the process of Adult Protective Services often shy away from making reports because of the fear that if they report, they may be responsible for taking away someone's autonomy from them. And that's a real fear that folks have. However, I'm happy to say that that's not the case and that APS really opens the door to decision making. I think Erin did a really great job of explaining that. And I see APS as a resource and not a restriction. So older adults who have that capacity and have the ability to decide what services they want and they don't have to work with APS, as Erin stated earlier, if they don't want to. Obviously, there are legal components to this whole situation. That's not quite what I'm referring to, but I did want to acknowledge that. But even folks who do have limited capacity have that voice in their decision making and you know, do have a say in what happens with their situation. So, and I've learned this from APS caseworkers. All of the APS caseworkers who I've ever worked with highly value clients and listen to what they want. And I've taken their lead in that and learned that from them. So, you know, when in doubt, report. If you're a mandated reporter, you need to be reporting. But I hope that this message may make it a little easier and feel better about reporting, to know that, you know, it's not a restriction that you're placing on a person. It's opening the door to give them resources and help them make decisions if they're ready for that. So. And lastly, I want to leave you all with a few tidbits. So advocacy is completely possible in any role, no matter, you know, in what capacity you're working with someone. And so I also acknowledge that elder abuse is a really uncomfortable topic. Nobody really likes to talk about it. It's hard to think about, and I completely acknowledge that. But because we don't talk about it, people in abusive situations may feel some shame and some stigma and fearing judgment from others. So that's why it's really important that when we're designing services, they're safe and non-judgmental, and it's so important for those folks. And so in doing so, we can dismantle that shame and replace it with empowerment. Another important thing is to educate yourself and your organization about elder abuse. So talk about it, normalize talking about elder abuse within where you work. And again, we are available for training. So if you're interested in that, definitely reach out. Also combating ageist attitudes and beliefs when you hear them. And we can do that by acknowledging the value and contribution that older adults have in our communities. If you are working with someone who you think may be in an abusive situation, be prepared for some long-term support, and remember that that person will address their abuse on their own time. Teaming is super important. So creating a supportive and sustainable team around that person at the client's own direction is huge and a huge resource for them. Again, when in doubt, report to APS. And lastly, uphold and support older adults' right to make their own decisions, even when it's hard. And sometimes it is hard. And lastly, I want to leave you all with a quote from, again, Atul Gawande, and it's this: "A few conclusions become clear when we understand this, that our most cruel failure in how we treat the sick and the aged is the failure to recognize that they have priorities beyond merely being safe and living longer. that the chance to shape one's story is essential to sustaining meaning in life, that we have the opportunity to refashion our institutions, our culture, and our conversation in ways that transform the possibilities for the last chapter of everyone's lives. So this is my contact information and also the contact information for the organization itself. If you have questions, please reach out. I also did want to plug that we are hiring 4 new advocates throughout various locations around the state. And I'll be dropping the job description in the chat. So if any students are on the call and are interested, definitely, if you have questions, reach out to the info@eaime.org email address. So thank you all for having me.
Thank you so much, Emily. I'm just curious, do we have some time for questions? No?
No, but Kelly, we do, well, according to our schedule, we need to move on.
Okay.
But I wanted to say before we move to Dr. Nichols that those questions that are there for you, Emily, we will have an opportunity at the end of the next presentation to address those.
Okay, perfect. I did not leave enough time. I apologize.
Like a true advocate, Emily. Clock full.
Thank you.
So this is Frank Brooks, and it's a pleasure to introduce our next speaker, Dr. Stephanie Nichols. And Dr. Nichols is an associate professor of pharmacy practice here at the UNE School of Pharmacy. She's also adjunct clinical assistant professor of psychiatry at the Tufts University School of Medicine and psychiatric and substance abuse disorder faculty at Maine Medical Center in Portland. Dr. Nichols is dual board certified, as a pharmacotherapy specialist and a psychiatric pharmacist, and is a fellow of the American College of Clinical Pharmacy. So again, it's a pleasure to welcome you, Dr. Nichols, and we look forward to your presentation.
Thank you so much, Frank. And let me just get this up and going here. All right, and thank you to you all for being here with us today on this lovely Friday, and to all of the earlier presenters. I learned a great deal throughout the talk so far today, and I just want to make sure I have my time ready to go here. Okay, so by the end of this talk today, I hope that we were all able to review the Maine Adult Protective Services data in drug-related investigations versus non-drug-related investigations, describe risk factors for diversion of prescription medications from elderly patients, compare the epidemiology of substance use among older people and the general population, and list risk factors for at-risk and non-medical substance use and overdose among people who are older. So I would like to begin by talking about some risk factors for elder abuse and the relationship to substances. And we've heard a lot about these risk factors already throughout today, so this should be a review. But some risk factors, and I would be remiss if I didn't acknowledge where this data is coming from. So this slide, as well as the next several slides, I'm very excited to present. And this comes from a report that was developed by Snow, Pratt, and Bratzman, who are part of USM Muskie School of Public Health. And this is a report that they wrote in November of 2020 for the Maine DHHS Office of Behavioral Health. So what they found in their report is that risk factors for victims of abuse can include many different things, such as functional dependence or disability, poor physical health, cognitive impairment, and we just heard a lot about that just a minute ago, poor mental health, and then low income or socioeconomic status. And it's important to understand that opioid use, regardless of whether it's medical opioid use, like prescribed opioids that somebody is using medically as prescribed, or non-medical use, both of those can contribute to and exacerbate these risk factors for victims. So any person, any elder that's on opioids or uses opioids, even if they use them medically or non-medically, can be at increased risk. And I do want to just take a second here to do a language check. You'll notice that I'll talk about substance use disorders and not substance abuse or non-medical substance use rather than substance abuse. I think it's important to differentiate between those things, particularly when we're talking about something like elder abuse. So just a language check there. So we talked about some risk factors for victims of elder abuse, but what about risk factors for perpetrators of elder abuse? There are a few that are known. So some risk factors for perpetrators include untreated mental illness, non-medical substance use, as well as dependence on the older adult. So if it's somebody that lives with the person or is otherwise dependent on them. And we noticed some of that in our case with Mr. B. We noticed that Mr. B's granddaughter is at least partially dependent on him, and that's something to note. We also understand that substance use among perpetrators is associated with financial exploitation, as well as physical abuse, emotional abuse, and perpetrating multiple different forms of abuse at the same time. So there's a really important relationship between abuse and substances, and there are many different directions of that relationship, not only just substances being at play medically in somebody who may be being abused, but then also if there is any sort of substance use disorders going on with the perpetrator as well. So some more data from that report that I mentioned. So this is an analysis of the Maine Adult Protective Services Information System on elder abuse cases. So on the left-hand side, you can see a table that reviews just over 90,000 investigations in the years 2015 to 2018. You can see that about 6% of total investigations were drug-related. About 6% were related, and 2.5%, so a little under half of those were opioid specifically related. You can see here that the proportion of those investigations that were opioid related did remain consistent over time. Now, if you look on the right-hand side, you can see investigations where there were search terms that were able to be reviewed. And of those nearly 2,500 investigations, opioids made up about 9% of those with search terms that were reviewed. So we'll start here on the right-hand side, looking at the proportion of people who are older in a given county. I just have to move my picture thing there, as well as the opioid-related and other illicit drug-related investigations. And so you would expect that the percentage of investigations would align pretty similar with the percentage of the population that's age 60 or older. And in many counties, that is true, but there are a few outlying counties. So you can see, for example, in Androscoggin and Cumberland County, the rates of opioid-related and other illicit drug-related investigations were actually lower than would be expected for the population that's 60 years of age or older. On the flip side, Aroostook County and Kennebec County actually had much higher rates of these drug-related investigations as it relates to the proportion of patients 60 years of age and older. So going to the left-hand side here and looking at this map of Maine, I think this is also really interesting. So you can see here that non-opioid related investigations fairly match the population distribution of Maine. But what I find very fascinating about this data is if you look at the darker color here, these are opioid-related investigations. And you can see that the opioid-related investigations specifically tend to travel along the interstate corridors or along the borders of our state. So what are some factors associated with drug-related investigations? So here we'll talk about some client factors. So when we have clients with drug-related investigations, they're more likely to live with relatives. So you can see that down here in this second darkest blue color. So more likely to live with relatives versus investigations that are non-drug related. And clients with drug-related investigations and opioid specifically related investigations are less likely to live in long-term care facilities and other service facilities. On this other picture here, you can look at the clients with opioid-related or other drug-related investigations and their age distribution. So you can see here that opioid-related investigations, the clients tend to be younger within that, that older age range. So these patients tend to be between 60 and 69 years of age, more likely, versus non-drug related investigations, where nearly half of those clients were 80 years of age or older. So those are some client related factors, but what about investigation related factors? So opioid related investigations, so opioid specifically, those investigations were more likely to have 3 or more allegations. So when you look down here at opioid related investigations, about a third of those involve 3 or more allegations, and a small minority, only 27%, involved 1 investigation. This is much more common to have more investigations with opioid related investigations versus non-drug related overall. And then on the right-hand side, you can see here that nearly half of opioid-related investigations involve exploitation. So exploitation was involved with 47% of the opioid-related investigations versus 30% with non-drug related. And then finally, thinking about perpetrator-related factors. So alleged perpetrators are more likely to be living with clients in drug-related investigations. And so you can see that down here. So both drug-related, non-opioid drug-related and opioid drug-related, the alleged perpetrators are much more likely to be living with clients versus non-drug-related investigations. And then on the right-hand side over here, we can see that alleged perpetrators are more likely to be children or grandchildren of clients in drug-related investigations. And so we can see children in this darkest color bar here for both opioid-related and other drug-related investigations, and then grandchildren in the second darkest blue color bar here. So opioid-related investigations, more than 50% are related to either children or grandchildren of the client, versus about 40% with non-drug related investigations. And so we've talked a lot about the role of opioids and opioid related investigations. So are opioids really common among people who are older? Yes, they are. So looking at prescription opioids in patients, you can see here the age distribution, and honing in down here on our elderly patients, patients who are 65 years of age or older, 25%, 1 in 4, have at least 1 opioid prescription. Opioids are very common in this age group, and common overall. You can see at the top, 15% of the population overall has had at least 1 opioid prescription. But in our older patients, we're talking about 1 in 4. So opioids are commonly prescribed in our older patients, and we know that non-medical opioid use is also very common overall in our overall population. So where are these opioids coming from? Well, you can see here on the right-hand side that the orange are opioids that are obtained for free from friends or relatives. This yellow color is opioids that were bought from a friend or relative, and green is stolen from a friend or relative. So more than half of non-medical opioids come from a friend or relative, either being stolen or obtained otherwise for free, bought, or bought. Less than half of non-medical opioid use comes from other sources, including strangers or drug dealers, being stolen from a medical system in some way, or via multiple prescribers or doctor shopping or even pharmacy shopping. So the majority of non-medical opioid use comes from friends or the opioid source comes from friends or relatives. So thinking a little bit more about that and diving in a little bit with regard to demographics, so age and gender demographics, you can see here that, again, the majority of the opioids that are obtained for non-medical use are obtained for free from the friend or relative. However, if you look at the, over here at the column of opioids that are obtained, that are taken from friends or relatives, you can notice that younger people are more likely to obtain non-medical opioids that way versus older people. within still a fairly young age range as we're talking about today, certainly. So when I say older people in this slide, I'm talking about 35 years or older. The other thing I want to point out here is that as people get older, people who are using opioids non-medically get older, they're more likely to either, even more likely on top of the already more likely, even more likely to obtain it from a friend or relative for free or buy it. And also, I found this quite interesting. There's a gender difference here where females tend to be even a little bit more likely to get the opioid for free for non-medical use, whereas males still are more likely to get it for free, but versus females are more likely to have bought it from a friend or relative. So we have all these opioids around and people are using them non-medically, and more than half of those are being obtained in one way or another from a friend or relative. So I would be remiss if I did not talk about proper opioid storage and disposal. Very important to prevent diversion. So this is a study that we published a couple of years ago looking at patients who had thoracic surgery and were discharged on opioids. And the aim of this study was really looking at identifying factors to reduce, to help identify how much opioids would need to be prescribed upon discharge in patients after thoracic surgery. But one small part of this study that we looked at was also storage of the opioids in these patients post-op, storage of their opioids and disposal of their opioids. And what we found, not surprisingly, but concerningly, is that only about 10% of opioids were actually stored in a locked storage location. About half, a third to half of those were stored in a medicine cabinet or box. And then another significant portion were stored in cupboards or wardrobes. Also, I think important and concerning, although not super surprising to me, was that very few opioids were disposed of. So only 7% of all unused opioids were disposed of across the 4 weeks. And of that 7%, over a quarter inappropriately disposed the opioids directly in the garbage. So I think we have a lot of opportunity to educate people around proper opioid storage and proper opioid disposal. Another source that I wanted to briefly mention of diversion is in the transition between hospitals to nursing homes or other long-term care facilities. So this author group was working on a different pilot program assessing and improving the transition of care between these two locations. And as part of their work, they identified that there were a lot of missing meds that kept coming up. And when the medication investigation, the missing medication investigation was further looked into, it was determined that one source of missing opioids was actually occurring via transport. And so these authors brought up the risk that opioids, that's another source, a potential source of opioid diversion, is in the transport between a hospital and a long-term care facility. So why do we care a lot about opioids in the community and even non-medical opioid use, right? Well, we care for a lot of reasons, but one of the major reasons why we care is because we know that opioids are very toxic, and people die with too much opioids. But if we take a broader perspective here and actually think about not only just unintentional overdose, but also think about deaths by suicide, and we combine these two together. So combining deaths by suicide and deaths via unintentional overdose, and we term these deaths of despair, which was coined, I believe, by Dr. Boner, then we can actually see that the proportion of opioids in these deaths of despair is rising pretty dramatically. So what we're looking at here for colors, the orange is 2000, Then you've got 2006 in yellow, 2011 in green, and 2017 in blue. And so deaths by suicide are rising. Certainly unintentional overdoses are rising. So you can imagine the deaths of despair overall are rising, but the proportion of these deaths of despair that involve opioids, particularly in 2017, has gone up from 17% in 2000 to 42% with our most recent data. So the amount of deaths of despair that involve opioids have more than doubled in the last 20 years. So overall, people who are older, and this here on this slide is defined as greater than 50 years, people who are older accounted for 39% of drug use deaths worldwide by 2015, according to the World Health Organization. And in those who are 65 years or older, opioids were linked to 75% of the deaths. So I wanted to just briefly talk about some general risk factors for overdose. These are risk factors for anybody who might be at risk for overdose, but I want to hone in on a few that are more related to medical use of opioids. So we know certainly there's a dose-dependent risk of overdose. Anyone who is prescribed or using opioids in any way at doses of 50 morphine milligram equivalents or greater is at increased risk of overdose. And this is not just on or off. The more morphine milligram equivalents, the higher the risk of overdose. And it's not a linear increase either. That risk of overdose starts to spike as you get above 100 morphine milligram equivalents. Use of opioids with any sedating or respiratory depressing substances also increase risk of overdose. So if we have patients that are on opioids plus benzodiazepines like Valium or Ativan, plus barbiturates like phenobarbital, plus alcohol, plus other sedatives like zolpidem or other hypnotic agents, muscle relaxants like Soma, or even antipsychotics, all of those can interact with opioids and increase the risk of overdose. Anyone who's using opioids with a medical condition, specifically medical conditions that increase the levels of opioids, such as if they are on drugs that interact with the opioid, or if they have organ dysfunction like liver or renal disease that reduces the elimination of the opioid. Anyone who's more susceptible to respiratory depression because they have COPD, for example, or maybe a history of sleep apnea. And then also anyone who's at increased risk of suicidal ideation and death by suicide. So specifically thinking about our patients with depression and bipolar disorder, but that is not in the exhaustive list by any means. And then finally, again, back to access to opioids in the home by those other than the patient, including children, pets, but also others, right? Family, friends, and even strangers.
Stephanie, this is Frank. Before we go on, do you want to take a question about deaths of despair that you would?
Yes.
Okay. Participant has asked, I would be curious as to the gender breakdown in the deaths of despair.
Oh, yes. So I had that slide. Thank you for asking. I had that slide and I actually cut it because I was worried about time. So let me see if I can remember correctly. So oh, nope. You know what I'm thinking about? It's not specific to deaths of despair. It's only just opioid overdose. So whoever asked that question, if you would like to email me, I can get back to you about the specifics of the gender breakdown for deaths of despair, because all that's coming to mind right now for me is just the opioid overdose and not including death by suicide. So I do want to give you a correct answer to your question.
Thank you.
I'll just say for opioid overdose specifically, the population that actually has the greatest increase in rate of opioid overdose is women, and it's women that are sort of in the middle ages. So kind of, I don't remember exactly, but I want to say 35 to 55 or so, and that's the population that's having the greatest increase in rate of overdoses.
Great.
Great, thanks, Frank. And please feel free if anyone has any other questions. I certainly welcome them. but I'll keep going while you're thinking about them. So now I want to talk about reducing the risk of overdose. And you might be looking at this slide and be wondering, why is it starting with number 5? We will get to number 1 through 4 in the next slide in a second here. I kept the numbers the way they are because these are the guideline recommendations. And so I kept them to align with the numbers in the guidelines. But I switched the order of them to present today because it makes more sense this way. So we're talking about overdose and reducing the risk of overdose. And so the guidelines, we now have Canadian guidelines on opioid use disorder among older patients. And there are several recommendations, including reducing the risk. So in patients who have polypharmacy, so maybe they're on opioids plus benzodiazepines or other comorbidities, we always want to use the lowest effective dose of opioids and consider a tapering, particularly if the opioid's not working well. When we taper, it's really important to do a slow outpatient taper, and slow is really slow here. And that's preferable to reduce the risk of overdose. If we taper patients too quickly, we now understand that that is a major risk factor for opioid overdose. There are situations where a quicker taper is appropriate and necessary, and in those cases, it should be done in a medically supervised setting. Certainly, we can't forget about naloxone. I'm always banging the naloxone drum. So naloxone in anyone who's using opioids regularly for any reason, prescribed or otherwise. If they're using opioids regularly, naloxone should be dispensed to them and should be ready in case. And the person who's overdosing cannot administer their own naloxone. Somebody else needs to administer it. So it's so important that household members and support staff know where the naloxone is and how to administer it before an emergency occurs. It's important to include skilled pharmacists and nurses and other members of the interprofessional team to educate patients on appropriate use of opioids. And in any older adult who is at risk for or who has an opioid use disorder, they should be given advice on strategies to reduce the risk and information on supervised consumption sites if available. Now, again, these guidelines are from Canada. They have supervised consumption sites in Canada. We don't have them in the US quite yet. So that's reducing the risk of overdose, reducing the risk of development of opioid use disorder. So in patients with acute pain, we want to use non-opioids first or use the lowest effective dose of the least potent immediate release opioids. And use them for a very short amount of time, so usually less than or equal to 3 days, and very rarely more than 7 days. In most circumstances, we're going to avoid the use of opioids for older adults who have chronic non-cancer pain, because the risk versus benefit often is not in favor of using opioids. There are some exceptions to that rule, certainly, but in general. We want to advise everyone to store opioids safely. I've talked a lot about opioid storage, but it's really important. Store opioids safely, don't share your medication, and return unused medication for disposal at police stations. There are take-back days that occur regularly throughout the state, and I'm sure in other states as well. And some pharmacies are now also taking opioids back for disposal. In a pinch, in an emergency, preferable to throwing the opioids in a garbage for opioids specifically would be to flush them in a toilet if there's an emergency. That is an acceptable route of disposal for opioids. Most other medications, it's not recommended to do that, but with opioids, because of the risk of overdose, that is one thing that can be used in a pinch. But I mentioned the preferable disposal locations a second ago. And then finally, pharmacists and nursing staff, and really anyone on the interprofessional team is advised to inform the prescriber if there are concerns with co-prescribing, adherence to treatment, or intoxication. So thinking about identifying opioid use disorder in older patients, it's tricky. Older patients, the opioid use disorder does tend to present more subtly. It often doesn't look the way that we have preconceived notions about with regard to opioid use disorder, and it often requires a much more nuanced approach. Many of the symptoms of physiologic opioid tolerance overlap with symptoms and behaviors that we see in patients with opioid use disorder. And so again, it's very complex to tease this out. Further, other medical conditions that people who are older are more likely to have can also look like or mimic behaviors that we see in patients with opioid use disorder. Sometimes consequences go unrecognized in patients if they aren't working or if they're not really interacting with people. Sometimes it's opioid use disorder just kind of falls under the radar. No one really notices that this is a problem. And then finally, social stigma and cognitive impairment are also important factors that contribute to underdiagnosis of opioid use disorder in this population.
Just a heads up, Stephanie, we have a couple minutes left.
Perfect, thank you. I think this is my last slide that I'm going to go through today, so good timing. So the last thing I want to say is that more older adults are in opioid use disorder treatment now than they were even a few years ago. So looking on the right-hand side, you can see percentage of participants in opioid treatment programs. This one was in New York City, but this is consistent with other studies. In patients that are greater than 60 years of age from the year 2006, and it was less than 2% versus the year 2012, where we're looking at well over 10% now. And in this study, they also noted a shift from illicit drugs to those obtained by prescription as the primary type of opioid used. So opioid use disorder certainly can happen in older adults, and it's something that we need to be paying attention to and thinking about as well. So with that, I thank you, and I wonder what else you are wondering.
Thank you, Stephanie. Excellent presentation. I do have one quick question. Stephanie, would you tie that last slide, the increase in those percentages, to the overall flooding of the whole society in opioids of all different types?
Yes, I absolutely would, Frank. Thank you. Yes. Our opioid prescribing rates have gone up dramatically since 1999, and there are many, many different reasons for that. But certainly, I think that that our older patients are not immune to developing opioid use disorder, and many older patients, just like many younger patients, started with prescribed opioids and then developed the opioid use disorder as a result of that.
Yeah, thank you, thank you. So, folks, please put your questions for Dr. Nichols and any of the other presenters into the chat. And I know Kelly Fox is going to help monitor the chat. But I just want to thank all our presenters for this, talk about an array of issues that are connected and correlated, and yet all deserve a separate attention and knowledge. I ditto what you said, Stephanie Nichols, on learning a lot from the presenters. So I have one question from before that I don't think we addressed, but I know a number of you as presenters could make comments about, and that is different forms of financial abuse or financial exploitation as a form of older adult abuse. And any presenter can address that. I'll leave it up to you folks.
I can address that one. I think when we think about our definitions within adult protective services, we do have distinct definitions for abuse, neglect, and exploitation, and they all have different meanings. But I don't think there's kind of in thinking about elder abuse as a topic in general, I think exploitation does fit under that bucket for general discussion purposes. But there are some distinctions that we rely on when we reach our findings.
Mm-hmm. Thank you. John or Heath, do you have any comments about that? I think you touched on it, but what percentage of your cases are financial exploitation?
Heath may be better able to answer this than I. I typically only see cases once they're fully investigated and ready to go to court, really. But in terms of the intake, I think we have a fair number of those. We tend to push financial exploitation towards a dedicated elder abuse and exploitation prosecutor who handles the financial side of things. She's more focused on family-based exploitation and that kind of thing. We tend to concentrate exclusively on providers. So if we've got a provider that's stealing from a healthcare consumer, we'll take that up. Those are fairly rare. The vast majority of our caseload is abuse and neglect of vulnerable adults. And we concentrate beyond that, we'll have some concentration on financial fraud, but that tends to be against the system as opposed to individual healthcare consumers.
Oh, that's right. Yeah, you had talked about that too, that people who are defrauding the healthcare system, which may be on behalf of older adults, right?
Yeah. And our victims, when we have an individual victim, they're much more likely to be the victim of abuse and neglect. And the financial exploitation tends to go to Suzanne Russell, who's a very experienced prosecutor in our office dedicated to exploitation of vulnerable adults.
Great, thank you. And Heath, do you have any comments?
No, I think John hit the nail on the head there. There's outside of our unit, there's another detective within the AG's office that his only work is on financial exploitation with older adults. So he would primarily handle those cases.
Great. Well, I'm glad that area is covered. Thank you. Here's a question from Kaylee Nevin. Is naloxone similar to Narcan?
Yes, I'm glad you asked. So I try to refer to drugs with generic names just to reduce any risk of bias. But yes, the brand name of naloxone is Narcan. There are 4 different formulations. There's the nasal spray, the Narcan NS. FZO is the auto injector, which talks to you. It's very expensive, but it talks to you. So that can be helpful if people can get it via grants or otherwise. Then there's the usual form that's an injectable form. Usually that's drawn up into a needle via a vial or a carpuject. And then the final form that we used to use before there were the FDA nasal form and auto injector forms are the naloxone kits. So you might see some people that have the Narcan kit where they are taking the carpuject and screwing it onto an atomizer, and then that can be used nasally.
Okay. I think there's also confusion between naloxone and naltrexone. And can you explain the differences between those two?
I would love to. Yes, thank you. They both work the same way at the receptor, and that they're both opioid antagonists. So they'll both block that opioid receptor, kick opioids off the receptor if they're on, or block it from opioids being able to bind to that are administered after. The difference really lies in the ability for absorption. Naloxone is not absorbed at all orally, and that's why we use it other ways, and it has a more fast onset of effect with nasal or injection. But then B, the duration of action is also very different. Naltrexone, we can give orally as a tablet or as a long-acting injection, Vivitrol, and the tablet lasts about a day. The injection lasts about 30 days, whereas naloxone is very short-acting, quick onset and quick offset. It only lasts about an hour or 2.
Yeah, thank you. Both very important drugs to know about. Thank you. Peggy Spencer from one of our co-sponsoring organizations has put the link in for the completion of the evaluation, which has to be done by June 2nd to get your CEUs. And the link is right in the chat. So that's a little housekeeping item. But back to some comments. People were talking about the difficulty in some of this work. And I think it was Shelley, Cohen, Conrad asked, how do folks who are doing this difficult work prevent burnout, or how do you take care of yourselves in some of these very difficult circumstances? Because I think you all have unique, difficult circumstances that you were talking about. And I don't know, Erin, if you wanted to talk about that first with regard to the APS casework staff or not.
Sure, I can kick things off on that topic. I was reflecting on it since I saw Shelley's question earlier, and I think in some ways I'm lucky and grateful to be a part of a team that is smaller in some ways, and there are really close relationships in terms of supervisors and coworkers, caseworkers being able to just have those conversations. I had a tough case today, and here's what it was like, and working through those one by one with supervisors. Are there different ways we could approach this, or are we at the end of the line in terms of what our intervention might involve? And just being able to have those conversations openly makes a really big difference, I think, just to process and address that when you're feeling worried about someone and feeling like there's nothing else that can be done. So that's certainly not the end of the conversation when you think about burnout and kind of just the self-care piece that needs to come with doing any kind of direct service work. But I also think in some ways, the role of adult protective services or anyone working with older adults, it's powerful and it's rewarding to be able to support someone in their own self-determination and their own autonomy. So sometimes we're getting cases where it really is some of that, people with well-intentioned thinking that they're going to intervene in someone's life who doesn't want that intervention and doesn't need it. So for instance, oversimplifying answer, but we've received calls, this older person I know isn't bathing on a regular basis, or they stopped shaving their face. That's their choice. And being able to support that person and remind others that that is someone's own personal decision as an adult is rewarding, I think.
Mm-hmm. Thank you, Erin, for bringing that up too, because that's another part. What are some rewards of the work that you've done? Because it's certainly a lot of you, Emily's your advocacy work. What are some of the rewards of your advocacy work that you have noticed?
Yeah, I think just having the honor of being invited into someone's life is a huge reward to any extent. I really enjoy talking to my clients, learning about their life, their history, who they are. That's what I enjoy most about my work, is building that rapport and those professional relationships with my clients. It's why I do what I do. And also being able to talk here with you guys about elder abuse is very rewarding because it's always great to advocate on this level. So that's what I would say. And to the burnout piece, I know there's a lot of students on the call. And so I would just say, not being afraid to use your PTO is huge. I'm not great at it, but not being able to utilize that.
You mean personal, what's PTO?
Your personal time off. So if someone, if that's in your job, you usually have a lot of time off. So don't be afraid to take your time off. Also having pretty strong boundaries and revisiting those boundaries is really important on both keeping yourself safe and your client safe as you're building those relationships. And then I would also say supervision, having that strong team like Erin was saying is huge, and being able to talk freely about when you're feeling burnt out and acknowledging those red flags and when that wave of burnout is coming to prevent it. So that's what I would say.
Thank you, Emily. We have some questions coming in fast and furious here. One of the panelists, this is from Heather Putnam, one of the panelists briefly note the importance of an investigation of abuse or neglect to be open to or not rule out that the abuse of the older client may include sexual assault. I'm wondering too, boy, that all of you probably could address that. Erin, do you have any idea about the percentage of reports that you get that might be sexual assault related?
We just under 5% of the cases that we receive are allegations of sexual abuse or sexual assault. And we're certainly working with law enforcement very closely in those types of cases. I think in terms of kind of being on the lookout for that as a possibility, that's something that we do talk about, because it may be that physical abuse is what is reported and there is more going on that needs to be explored. So when we think about how we interview clients, how we talk to clients and build that rapport, being on the lookout for things like coded messaging. So if someone says, do you investigate other things besides abuse? That might be someone's way of testing whether they can open up about things like that. And really just doing that observation and getting a sense of, is there more that needs to be explored?
Yeah, so that's part of your training of APS caseworkers and people, or the whole staff.
Right.
John or Heath, what do you have do you refer cases on that you hear about with regard to sexual assault of older adults into a specialized unit?
No, that's something that I would investigate and have investigated. So if the assault is coming from a provider, then I would have jurisdiction into that. If it's from a family member, then I may not have jurisdiction, and that's where I would get local law enforcement involved. But generally speaking, if I'm made aware of it, I'm going to look into it and investigate it.
What percentage of your cases would you say that involves sexual assault, Heath?
Yeah, it's not a very high percentage for me personally. I think it's pretty low. I can only think of probably 5 to 10 cases that I've handled thus far that were sexual assault related, over the course of the last 4 years for me personally. So not very high.
Okay. All right. Well, thank you. Thank you. And thank you for the question, Heather. So I'm noticing that there's something going on with the connections to the survey, and Peggy Spencer has put up an alternative. So I just want everyone to note that if you want a certificate. There are so many other questions. We're running out of time. We're almost at 12:30. I can't believe it. We could go on for another 3 hours, I know. So what I'd like to do is thank all of our presenters so much for these excellent and superb presentations and so much information. And you did work so hard to make it work in the time frame that we had, and because we could do 1 or 2 day trainings on all of the topics. So thank you, presenters. And on this last slide, you'll see that there's that survey connection. And I believe that all of you as participants can contact us, and we can get you slides, we can get you contact information, we can do anything to connect you to these fantastic presenters. And I also want to thank the presenters for your hard work and just all that you do to help older adults in Maine have better lives. I just think it's so important. And it's certainly been a benefit to the School of Social Work and all the Triad students and all the Triad faculty and staff who have connected with you to be able to benefit from your knowledge and expertise. So thank you very much. And with that, there's another thank you slide, which is full of thank yous. We're social workers, right? To our collaborators, speakers, students, the Cumberland County, the CCSME, colleagues, friends in the Triad team, and everybody who made this possible. Oh, also our reader theater actors, Sage Landry, Bob Young, Polly Bunnell, Tiara LaPierre, who also ran this show today, Jennifer Curran, Irene Kagugu, and Stephanie Worth and Briellen Crowley. Thank you for our readers theaters. So any last comments in the chat before anything that I've forgotten?
Just want to say thank you to our presenters and to our students, and for others from the community who are here. It's a great presentation. I really appreciate it, and great interaction.
Great. Thank you, Kelly. And thank you for all your support in the chat and all of that. That was really important. Okay. So I think it is time to end. Tiara, are we all set to end at 12:30?
We are. Thank you, everybody. Have a good afternoon and a great weekend.
Bye, everybody.